Namaskar and good morning, everyone. A very warm welcome on the second day of the webinar on management of breast cancer in New Millennium, recent clinical updates from SABCS. With immense pleasure, I would like to welcome Dr. Som Shekhar SP, who is Chairman and HOD Surgical Oncology, MHEPL, consultant, surgical and gynec oncology and robotic surgeon, HIPEC, super specialist, Manipal Comprehensive Cancer Center, Manipal Hospital, Bangalore, for his welcome and introductory note and to set the ball rolling. Over to you, sir.
A very good morning to all the delegates, faculty, and at the outset, I would like to thank the organizing committee for bringing this wonderful session today, the best of SABCS, the treating breast cancer in the new millennium. So we have divided into three sessions. These abstracts, our co-conveners are there with me, Dr. Megha Tandon and Dr. Rohan Khandelwal, and we have a very eminent panel today. The first session is going to focus on recent advances in the management of axillary lymph nodes. The surgical abstracts. The five abstracts have been shortlisted for this. We have very eminent faculty with us to present these. The format is we will be having 5 minutes for each presenter. So we'll finish the abstract presentation in 25 minutes. Then we have a brief panel discussion around 15 minutes. So we should stick to time and try to finish the session by 11:40 because we have two more panels to follow after this. So with that, I would like to welcome all the faculty, my co-conveners, Megha and Rohan. Rohan, you want to add something, Megha?
Thank you, sir.
Hi, Megha. Good morning.
Hello, sir. Yeah, so I am attending this at 5:30 in the morning, and I'm very sorry, my throat is a little bad. I'm in UK right now, so it's nice to have you all here.
Thank
and
you.
We hope for a great meeting. The first day was really good. So we hope the second
we had
day
a wonderful video session yesterday.
Yes.
So I think if the time is up, Rohan, you are around?
Sir, I'll just welcome you first. We have our moderator today, Dr. S.V. Sdo, who is Head Department of Surgical Oncology, BRA IRCH, and National Cancer Institute, NCI, All India Institute of Medical Sciences, New Delhi. And he will be inviting the session faculties. Over to you, sir, to coordinate the session. Thank you.
Thank you, Ekta. So we'll set the ball rolling. The first speaker is none other than Dr. Kanchan Kaur, a very good friend, very eminent faculty in Delhi. She is the specialist oncoplastic breast surgeon, director at the Medanta Hospital. She's in charge of the breast services, and she's going to speak on options for reducing risk for lymphedema when ALND/regional nodal radiation are needed. It's a very relevant topic for Indian setting. Dr. Kanchan Kaur.
Good morning. Thank you, Dr. Dio, for the lovely introduction, and what a wonderful and brilliantly planned and executed meeting. But I must say, I'm seeing Dr. Gaurav Agarwal sitting outside in the sun, and
Yes,
I'm I'm myself tempted to walk out and sit in the sun. So I'll without further ado,
This is the only day I could afford doing it, so I
Yeah.
can't.
Yeah, for a change, we have really good sunshine here as well in Delhi today. So, is my slide visible that
Yes.
I've shared? Yeah.
Yes,
Okay.
Kanchan. Yeah, you can put them in the slideshow.
Okay, I'm just going to do that. So I'm Dr. Kanchan, and I shall be presenting today one of the SABCS abstracts on options for reducing risk of lymphedema in patients in whom axillary lymph node dissection or regional nodal radiotherapy are needed. We all know and we all dread this complication of lymphedema, both patients as well as the treating clinicians. If approximately 1 in 5 breast cancer survivors will develop breast cancer related lymphedema, and it is undoubtedly one of the most severe side effects of breast cancer treatment that has significant impact on the quality of life. So we all know what the independent predictors of lymphedema are. The more you disrupt the axillary nodal channels, the more you're likely to increase the risk of developing lymphedema. So axillary lymph node dissection, where more than 10 nodes are removed, is at the top for the risk associated with lymphedema. Then nodal radiation is an independent predictor, body mass index of more than equal to 35 kg per meter square. And also interestingly, Taxol therapy when given with AC is also known to increase the risk of lymphedema. The stages of lymphedema, we know fluid accumulates in the interstitial spaces, leading to adipocyte hypertrophy and irreversible fibrosis. We see this kind of pitting edema in clinic early on, which later on, as it moves through stages, becomes irreversible and leads to the most dreaded elephant-like arm. The purview of this talk is primarily surgical management, which could be both in the preventive setting as well as in the treatment setting. The surgical management in the preventive and treatment setting both are now looking more and more towards establishing better lymphatic channels in an axilla where these channels have been disrupted either due to surgery or radiotherapy. But we can't move forward, obviously, until we quickly go over what the conservative approach, both in the preventative as well as in the treatment setting is, where compression, bandaging, manual lymphatic drainage, exercise, and the whole list of do's and don'ts that we give our patients, all with the view to symptom improvement, reducing risk of infection in the lymphedema arm, and hopefully volume reduction. But we all know that these can fail miserably. And that's why the better options are being looked at. I'll start with what is one of the worst surgical procedures to be offered, which is an ablative procedure, which is done in patients who have developed irreversible, completely hardened fibrotic limbs. This is called the Charles procedure, in which debulking is done for preventing reaccumulation. However, there are high rates of complications with cellulitis and obviously nerve damage. But this is the most exciting surgical treatment now is the lymphovenous bypass, where lymphatic vessels in the affected limb are anastomosed to venules using microsurgical techniques, and connections are surgically created proximal to the site of lymphatic obstruction. It works best if it is done at the early fluid stage of lymphedema prior to chronic fibrosis having had set in. And that is why both in the preventive setting, when axillary nodal dissection is being done, or in early stages of lymphedema, this kind of a procedure is being shown to have very good results. This was presented in the abstract, a patient who had 5 lymphovenous anastomosis bypass, and at 15 months, there was a 61% reduction in the lymphedema arm, in the circumferential swelling. And there is this significant reduction in a prospective analysis of about 100 patients was shown to the percentage change over a year was 42% reduction, which is quite impressive. Other surgical procedure, which is actually being done by quite a few centers, is vascularized lymph node transfer, in which a lymph node with blood supply is transplanted, and these nodes are harvested from multiple donor sites, could be inguinal nodes, submental, supraclavicular, omental, or mesenteric. And the theories of function are that it either leads to lymphatic vessel angiogenesis, or the lymph node flap acts as a pump. Also, in patients who have lymphedema, the fibrotic tissue, when it is replaced with vascularized and non-irradiated tissue, allows better lymphatic flow. And also, when you're introducing a lymph node, you're introducing an immune system organ, which may help to reduce recurrent infections. Vascularized omental flap transfer is done by is also a method of doing this. The biggest advantage is that the donor site lymphedema is the risk is quite low, as opposed to if you were going to take lymph nodes from the inguinal area, where donor site lymphedema risk becomes higher. It can be harvested laparoscopically and also gives significant volume of vascularized lymphatic organ that fills the radiated soft tissue cavities in the axilla. Another interesting thing for patients who are having delayed reconstruction with, say, the DF flap, at the same time, in the same sitting, nodes around the superficial inferior epigastric vessels can be used as lymph node transfer simultaneously when breast reconstruction is being offered, and the superficial vessels with the nodes are then anastomosed in the axilla. So the takeaway points are, and I must stress this, is that prevention should be the primary goal. Lymphedema, once it happens, despite all measures, in some patients can take a very ugly turn. And with this excitement and the buzz of axillary de-escalation, I think all specialist breast units must look at performing less and less extensive axillary surgeries in carefully selected patients after MDT discussion. So patients in whom a sentinel node can be performed must not have axillary node dissection for N0 disease. And also now we're slowly inching towards sparing the axilla in those with few positive involved nodes and a favorable histopathology. Conservative methods also form an integral part of prevention, and in the Indian setting, where we are still a long way away from proper de-escalation or from having microsurgical teams helping us with lymph node transfers and lymphovenous anastomosis, the awareness of lymphedema and the importance of informing the patient about the risk factors that could aggravate lymphedema is of extreme importance, and all breast specialist units must have physio and lymphedema specialists as part of routine practice. Now, surgical methods are being increasingly shown to have promising results. And again, for teams that specialize in breast surgery, I think it's well worth investing in trained surgeons who can offer these in selected patients, especially those who are at the highest risk of lymphedema, preferably at the time of axillary lymph node dissection in the preventative setting. Thank you. I hope I kept my 5 minutes.
Yeah, thank you, Dr. Kanchan. I think you're just in time, and thank you for a wonderful overview for prevention of lymphedema. Rohan, if you agree, I think maybe you can finish the abstracts first and go, since we have a panel discussion. So we'll not have sufficient time to take on questions right now. Is it okay?
Yes, sir. Absolutely.
Yeah, I think that's what we'll do there, because you're moderating the whole session and you're doing a panel based on the same faculty in this. So I think better. But beautiful presentation, Kanchan. Passion is seen in her voice. Thanks.
Thank you, so. Thank you for
so much. Thank you.
So we'll move on to the next speaker, that is none other than Som. He just joined. Som needs no introduction. He's heading the surgical oncology division at Manipal Hospital, and he's also the president of APSI right now. So he's going to present an abstract, axillary management in upfront surgery, staging, local control, or both. The eternal debate, I think, continues. So let us see what Som has to say.
Absolutely. Thank you very much, Dev, and a warm welcome from ABSI and also SABC from Professor Meenu Alia and then Vikas. So this is a beautiful abstract. When we were looking at it, this filled into the concept that we have moved from maximum tolerable treatment, radical mastectomy, to modified to breast conservation, and then minimal access surgery in axilla. Now axillary node positive we don't do with post-knock and all the trials. but yet not compromising the cosmesis and quality of life. So we don't go above the ideal line of treatment in breast cancer and do mutilating problem like lymphedema or cosmetic problem, but we don't go dangerously conservative like de-escalation. This is an era of de-escalation, organ preservation, multimodality, but the de-escalation should not be so much that surgeon de-escalates, medical onco de-escalates, radiation de-escalates, combining all three de-escalation, because everybody thinks, no, I want to de-escalate. I don't speak to my radiation. He will say, I will give APBS single dose, not hyperfraction. Medical onco say, chemo less and less, no adrenomycin. All three de-escalate, disaster. So we have to understand the ideal line. This is a beautiful presentation. I really loved when I read all the surgical presentation. I almost read more than 150 of them, and we shortlisted these 12 which we have given through the committee of SABC. Thanks to the whole team. This is a beautiful presentation by Stephen Wang, and I really like this presentation, so I took this abstract. So the courtesy, the slide is from the SABCs. You know that we have paid 100 and then we borrowed these slides. The way the topic was covered was, what is the evolution of axillary surgery in N0? Second, with evidence. Second part is SLNB positive if you are doing a mastectomy. Then if you are doing SLNB, is SLNB then required? You know, this is one step over all N0, because we do axillary staging by high frequency ultrasound, do a core biopsy, positive, we do a clipping, so you can do a targeted axillary clearance. Are there any group of patient with just ultra staging of the axilla by ultrasound as per Sounds trial, you can omit SLNB? Then N0 suspicious lymph node in ultrasound, what do we manage? So the first part is axillary surgery in clinically and radiologically N0. This is a beautiful timeline which I really loved. You can see the way the timeline the author has given. 1970 NSABP 04, King's and Cambridge ALND standard, then 1980, then 1990 SLNB and the two trials, Milan's trial, and then the CAL-GB trial 9341, omission of axillary staging. Then we have for micrometastatic positive SLNB IBCHD AATRM in 2000. Then we have macroscopic SLNB positive Asacox Z11 for breast conservation, Amaros and Otaros, and also MA trial was there for extended. Then we moved to 2020. Those who attended, I almost attended all the SABCs in except the last year. This and the interpretation by the author in this. So first, NSABP 04. It was very clear, we know radical mastectomy, then 40% node positive. So when we did ALND, this 40% was picked up. Mastectomy, no axilla, RT was given to axilla, 40% nodes not addressed by RT. In the last observation group, 40% is left to God. Now we will see in SABP what happened. You need to address the axilla. But the beauty is, addressed by surgery or by RT, more or less they had same recurrence-free and overall survival. So at that moment, what today we are doing in Amaros, there was an indication a good therapeutic axillary RT in absence of axillary surgery gave pretty much the same. But the thing is, look at this. If you have done ALND, 10-year relapse as reported by NSABP was 1.4%. RT 3.1, pretty much same in Amaros, you can know 2%. Those who didn't operate, 17%. I attended Veronosis trial. You know, I did oncoplasty training program with him. And I remember him telling 40% of the time, you know, false negative rate of SLNB today is around 3 to 5%, which means best institute. No, less than 1% recurs. So 40% positive node, neither ALND done nor RT done, no systemic, yet only 17% recurred. So this is there, God is there above us. There is something that is happening, which means all the node positive disease in axilla don't manifest clinically in their lifetime. So this is where Asakos Z11 played around that. We know 5% of the time we leave disease and come, yet with the current adjuvant treatment, the in the NSAPP04, 40% you leave, no systemic therapy, no LND, no RT, yet only half recur. And here FNR is 9.8 with current systemic less than 0.5%. So there are a lot of things which is very clear. Clinically N0, ultrasound N0, no need to go and do, because even if you leave some disease which happens in 3 to 4%, they don't recur. And NSAPP32 also showed when SLNB is positive, 61.4% was the only node in that, which means very little other burden which don't manifest. Then we went to micro metastasis, IBCSG and AAT-RM trial. So if you compare both of them, in IBCSG up to 5 centimeter, that is T3, less than T3 was taken. But here it was confined to early tumor, but a very good number. Number of sentinel lymph node in IBCSG was 2 and here more than 1. And you can see that breast conservation was quite high. These two trials addressed a lot of breast conservation, which is current management. ALNDR observation, ALND observation. When they did in this trial, additionally 13% non-sentinel node were positive, which is true, which means under stop at SLNB, 13% extra burden is there in both the group. But look at both of them, practically overlapping. Overall survival, DFS.
Time, we have to just check the time.
Yes. Yeah. So both of them are pretty much the same. So 0.2% ALND and 1%. So this showed that you can observe micrometastasis. Then we got the Z11, Amaros, Otosar, and then Synodor. All of them actually showed that if you are less than 4 axillary burden, 10-year survival and recurrence is pretty much same in both the groups. So you can observe them. So this is the group which showed, all the 7 trials showed that when it is a low axillary burden, you don't have to worry. Last couple of slides. So even in mastectomy, when you did this particular area, because they omit the RT, there was no other problem. Now, when you have N0 with micrometastasis, no axillary RT is required and no dissection was required. Now, the last part is you have post-hoc trial, Senomac and Synodar. Post-hoc has to report fully. They also showed that when you don't do anything in axilla, just do SLNB, document and leave, and no axillary directed therapy, but conventional systemic therapy, none of them actually recurred, and you can still de-escalate in this particular, even in HER2 positive particular group where you can do, which is very, very important. And now the other issue was the sounds trial, where can the axilla do omit it? Yes, when you do a high frequency axillary RT as per the sounds trial, NPV was very high as 93 to 96%, and the sounds trial showed that there was no change in overall survival and do. So a good axillary ultrasound can omit in selected case under clinical trial. SLNB you can do and come out of it, this particular area. So this is what also the TAX-IS trial showed, that if you do an undissected axilla in a good ultrasound, you don't have to do. So this is what all of them showed. So I have analyzed this. Last 2 slides, micrometastasis, no LND, SLNB negative, no LND, low risk as per Z11 IBCSG, tangential RT of the BCT covers, MA URTC covered high risk, you can do comprehensive RT. Amaros trial told that clinically non-negative SLNB positive ALND can replace this. And this is also reflected from the group from India, where we published 14,950 SLNB, and we had a isolated recurrence of 0.2%. So this is the summary which I left. It's also published. We can go back and read in the journal. Thank you very much.
Thank you, Som, for a wonderful overview of the journey of axillary lymph node dissection. I know 5 minutes is really less to cover 100 years the story on evolution of axillary surgery. So we'll move on to we are running short of time. We'll move on to the next abstract. This will be by Dr. Suhani, who is Associate Professor, Department of Surgical Disciplines, AIIMS, New Delhi. And she's going to speak on, can radiation replace ALND after positive SLNB? Dr. Suhani, please.
Good morning, everybody. Good morning, Dr. Deo. Thanks a lot for having me here. So I'll just speak 5 minutes on can radiotherapy replace axillary lymph node dissection. after a positive SLNB in early breast cancer. So this is by Dr. Reshma, who's from the Department of Radiation Oncology, University of Michigan. And SLNB, as of now, we know that is the standard of care for management of clinically node-negative early breast cancer. As we saw in Dr. Somshekar's presentation, the NSAPP4 had some anecdotal evidence that axillary RT may be oncologically safe with less morbidity, though in a different subset of patient population. And there has been a lot of focus on de-escalation of surgical management of the axilla. So the author has basically reviewed the literature of two randomized clinical trials to answer the question if radiotherapy could replace ALND in this subset of patients. The first one is the AMAROS trial, which is a non-inferiority randomized control trial. The 5-year axillary recurrence rate was assumed to be 2% for ALND and 4% for axillary radiotherapy. It included, till 2008, it included tumors up to 3 centimeter, and from 2008 onwards, for the next 2 years, it included even included tumors from 3 to 5 centimeters. The standard ALND included level 1 and 2 with a minimum of 10 lymph nodes harvested, and the RT included radiation to all the 3 levels at level 1, 2, and 3, along with the supraclavicular fossa, 50 grain, 25 fractions. So clinically, T1, T2 were randomized into ALND or the axillary RT, and if the SLNB was positive. The primary outcome was the 5-year axillary recurrence rate, and the axillary recurrence rate included the axillary and the infraclavicular. The supraclavicular nodes were included in systemic metastasis. And the secondary outcome included the axillary recurrence-free survival, the disease-free survival, overall survival, and the arm mobility in terms of shoulder mobility, lymphedema, and the quality of life. So 4823 patients were registered, and finally we had 744 in one arm and 681 in the axillary RT arm. Just to focus on the patient characteristics that they included, 60% of their patients were postmenopausal. Up to 2 centimeter tumors were seen in almost 80%, so 82 in 1 and 78 in 1. Grade 1 and grade 2 tumors formed almost 70% of the patient population. The micrometastasis and isolated tumor cells on positive SLNBs were seen in almost 40% of the patients, and additional number of SLNs were harvested in were positive in 33% of the patient. Now, this AMAROS trial included only those included SLNs as only those which were blue or hot lymph node and not the palpable lymph nodes. So, if we come to the results now, they had axillary recurrence at 5 years in 0.43% in the ALND arm and 0.9% at 10 years. In the axillary RT arm, it was 1.19%. So although there is a difference, it was not statistically significant. The disease-free and the overall survivals were almost similar. The lymphedema, however, was significant at 5 years with almost double in the ALND arm. Now, at 10 years also, the lymphedema was more in the ALND arm as compared to the axillary RT arm. However, at 10 years, there were more second primaries after the axillary RT as compared to the group which had axillary lymph node dissection. So when we come to the range of motion, it was similar in both the arms. The quality of life in terms of the symptoms, pain, and body image was similar in both of the arms. And the axillary RT group had some increase in the restriction of arm mobility as compared to the ALND group, although this was not statistically significant. The second study is this one, which included up to 3 centimeters of clinically node-negative early breast cancers. And this also compared the axillary lymph node dissection versus the regional lymph node irradiation. The primary and secondary objectives were almost similar to the AMAROS. Here again, you see almost 70% of the patient population was postmenopausal, almost 62 and 68%. So 65% of the patient population had tumors up to 2 centimeter. Almost 70% were grade 1 and 2, and more than 80% were ER positive tumors. The median number of lymph nodes that were identified were around 1.8, and micrometastasis again was seen in almost 40% of the patients with positive SLNB. And in the patients who underwent ALND, almost 40% had additional positive lymph nodes on ALND, and 22% of those who had a positive SLNB and positive lymph nodes had 4 or more lymph nodes in the ALND group. And this analysis of their complications also included those patients with 4 or more lymph nodes who received the regional nodal irradiation. And this population formed around 23.3% of the patients with positive nodes. The axillary recurrences were similar. The overall survival and the DFS was similar. The only difference was again in the lymphedema between the two groups. And this was obviously worse when the patients had received both the treatments with the LND and the auxiliary RT to up to 30%. There is no separate analysis after excluding these. Importantly, again, the quality of life was similar. So the authors of this paper, they concluded that for patients enrolled with with similar profile enrolled with AMROS, the axillary lymph node radiation can replace ALND. And the question on the extent of radiation therapy obviously needs individualization.
So on, you need to conclude, please.
Yes, sir, that's the last slide. Yeah. So just coming to our perspective, one is that the AMROS trial was underpowered. The clinical profile that we have is very different from those in these patients. In our own data set, T1 tumors are approximately 5 to 6%. The axillary lymph node metastasis in T1 and T2 tumors is again 50 to 60%, because we see a greater burden. So stage by stage, we see a greater local disease burden as compared to the West. Our ER positive patients are only 50 to 55%. We see up to 30% of grade TNBC and a higher proportion of grade 3 disease. Almost 40% in this study had positive SLNBs who had micrometastasis and ITCs. And this is very different from ours, where we rarely see micromets on SLNB. Additional positive axillary lymph nodes are seen in around 40%. Clinically detected arm swelling in a clinical trial setting versus symptomatic arm swelling with the patient reports are two different modalities, and maybe quality of life is a better indicator to assess the lymphedema and its complications. In our country, the resources for radiation oncology radiation are very limited, and I guess in Delhi itself, in the government setup, we hardly have 3 institutes. Further, we have the Z11 trial, which says that no treatment up to 2 positive lymph nodes, although the patient profile and the tangential radiation that was given to the breast did have confounding effects. So I would conclude that SLNB would still be the standard of care for our patient population. Completion ALND could be preferred for macrometastasis on SLNB. Individualized patient management is definitely the need of the hour, and that should be done, as no one size fits all. Thank you.
Thank you. Thank you, Dr. Swani. I think the Indian perspective was really good, because we need to bring this into context in the entire overall theme of de-escalation. So we'll move on to the next abstract, none other than Professor Gaurav Agarwal, who is a professor of breast and endocrine surgery for Sanjay Gandhi Institute, Lucknow, and he is also the president of Breast Surgery International. And he is going to speak on preservation of axillary lymph nodes compared to complete dissection in T1, T2 breast cancer patients presenting with 1 to 2 metastatic sentinel lymph nodes, a multi-center randomized clinical trial. Dr. Gaurav, please.
Thank you, Dr. Dev. And thank you, the organizers, for this opportunity for me to be presenting at this very well attended meeting. Yes, is my presentation visible to you now? The slides? Yes, are my slides visible? Okay, yes. Thank you. So, well, I'll restrict to presenting the abstract which I'm allotted or I'm asked to present, which is the Synodar 1 results, rather the interim results of Synodar 1 trial. Well, conservatism in the axilla is the flavor of this month or this year, and then the previous 3 speakers have all spoken about similar theme. And so this trial is a multi-center Italian trial which randomized patients with 1 to 2 macrometastatic sentinel lymph nodes in early breast cancer patients into either having a standard axillary dissection or having nothing further done, and undergoing standard multimodal adjuvant treatment as required as per the stage and biology of the disease. Well, sentinel lymph node is indeed the standard of care now for axillary staging in clinically node negative cases, and axillary lymph node dissection to some extent remains the surgical technique when sentinel lymph nodes are macrometastatic. However, the advantages of or therapeutic advantages of ALND in selected patients with limited metastatic sentinel lymph nodes is now being questioned, and the conservatism in the axilla in early breast cancer patient with micro and a limited 1 to 2 macrometastatic sentinel lymph nodes in terms of avoidance of completion axillary dissection was initially based on the findings of ECOSOG Z11 trial. I just to recapitulate for the audience, this C11 trial randomized patients with who had undergone breast conservation surgery and were planned for whole breast radiation and had 1 to 2 metastatic sentinel lymph nodes. They were randomized into either receiving axillary dissection or no further axillary surgery. And this was this study design. And this study, the interim results, the final analysis, and subsequent follow-up analysis have all concluded that ALD did not provide any outcome advantages. However, the results of ECOSOG Z11 trial have always been taken with a pinch of salt for various reasons. Some of the reasons are listed here. Firstly, the trial prematurely stopped enrolling patients, leaving the overall trial underpowered to answer the question it started with. There were too many patients who were lost to follow up. Half of the patients had only metastasis in the sentinel lymph nodes, and the radiotherapy quality assurance was missing, with missing data for more than 2/3 of patients. Besides, the study was very selective. It limited patients of only such patients who were receiving breast conservation and whole breast RT. In other words, mastectomy patients were excluded. To some extent, our kind of patients, the developing world kind of patients, were totally, almost completely excluded. And an effort to see whether the ECOSOG Z11 trial results and recommendations would hold water in our context have been made. I presented a paper on this theme at the San Antonio Breast Cancer Conference myself some time back, and subsequently TMH group has also published on this. So the need for the Synodar 1 trial has been pretty much what we feel in India, the need for another trial to confirm or refute the recommendations of Z11 trial. The limitations of Z11 trial, they confound the interpretation of results, making it impossible to extrapolate the findings beyond the very low risk study population. And so the Humanitas Clinical and Research Center in Milan, they initiated this multi-center trial in various Italian centers. They started enrolling patients in April 2015, and the enrollment has ended in 2020, and the follow-up is ongoing. So they've been 52 different Italian centers who have enrolled patients, and patients who had T1 to T2 disease and N1 based on sentinel lymph node assessment limited to 1 to 2 macrometastatic sentinel nodes, and who had undergone either mastectomy or breast conservation were randomized into 2 arms. The standard arm is the axillary dissection arm, and the experimental arm is the patients who did not receive axillary dissection. So only sentinel lymph node biopsy was done, and all these patients had adjuvant treatment according to the MDT decisions based on their stage and biology. These are the enrollment criteria, pretty much standard. The important ones I must point out is that they were not restricted to breast conservation alone, irrespective whether patient underwent mastectomy or conservation. They were included unifocal tumors, patients who were age 40 and between age 40 and 75 years, and clinically node negative with no more than 2 sentinel nodes, which were
we have, I think, 1 minute maybe.
Okay. So, and there were standard exclusion criteria which are listed here. The primary outcome measure was overall survival. Secondary outcomes were regional and disease-free survival. 889 patients were randomized into the 2 arms, which were pretty much comparable or well matched, almost 50-50. A few patients were excluded because of protocol violation. The breast surgery was again very comparable, between 25 and 20 and 25% patients undergoing mastectomy. And the follow-up the median follow-up in the two arms is pretty comparable at 33 and 34 months. And here are the results in terms of auxiliary treatment. More or less very comparable results, and the important ones are at the bottom of this standard arm. Almost 44% patients had positive non-sentinel lymph nodes, and the mean positive non-sentinel lymph nodes were 1.4. But otherwise, in terms of mean sentinel nodes, median sentinel nodes, macrometastasis were very comparable, and there were some deviation comparable in the two arms. In follow-up, in the standard arm, and comparing them with the events in the experimental arms, the events were very comparable, and you can see the mortality, axillary recurrence, ipsilateral breast cancer recurrence, distant recurrence, and secondary primary tumor. They were all very comparable with the p-values very close to or quite high. And so there was no statistically significant difference in terms of survival and recurrence, both in intention to treat analysis and per protocol analysis. The recurrence-free survival and overall survival between the standard and experimental arm were very comparable, as also seen on the Kaplan-Meier graphs. And finally, just to see if this follow-up duration is adequate or not, the authors have compared the median follow-up of their own trial patients, which is 34 months, with 4 different other studies listed here. And it seems that adequate time has elapsed for the median axillary recurrence to occur, and they've also provided a comparison between Z11 and Synodar 1 trial. And then most important or noticeable differences are the micrometastasis is almost non-existent in the Synodar compared to almost 40% in Z11, and detailed RT data is also available. And between 20 and 25% of patients have undergone mastectomy in Synodar compared to 0 in the Z11. So based on this comparison or the results and the comparison with Z11, it seems that there is a convincing overlap between the results of Synodar 1 trial and the Z11 trial. And so it seems appropriate that we can now omit completion axillary dissection in patients with 1 to 2 macrometastatic sentinel lymph nodes in early stage cancers, irrespective whether they have undergone mastectomy or breast conservation, and based on and then when the patients are going to receive appropriate multimodal adjuvant treatment. The authors have posed an ethical question that is it correct now to continue to propose completion axillary dissection to patients who meet the study selection criteria, not just of Z11, but also of Synodar 1. And that is something for us to ponder as well. And I suspect many authors and investigators in India and other developing countries would now look at their own data sets and try and match these results. So thank you very much for this opportunity, and we'll discuss a little bit more on these issues during the panel discussion. Thanks again.
Thank you. Thank you, Dr. Gaurav. I'm sorry, I think we're running behind time. 5 minutes is grossly inadequate for these kind of data presentations. We'll move on to our last abstract in this session. This is by Dr. Megha Tandon. And she's going to speak. Dr. Megha Tandon is the Associate Professor, Department of Surgical Oncology, Safdarjung Hospital. She's speaking from UK. I think right now she's on a fellowship. She's going to talk on less is not necessarily more, a propensity-matched national analysis on effect and outcome of sentinel lymph node biopsies. Dr. Megha, please carry on.
Thank you, sir. I'm sorry, I'm having a little bad throat. Is my screen visible?
Yes.
And am I audible?
Yes, yes, Megha, please.
Right. Thank you, sir. So, good morning, all, and thank you, organizer, for this opportunity. I will be real quick. So, as we know that the previous speakers have emphasized that de-escalation is the flavor of this era. However, so we have moved from ALND to sentinel lymph node biopsy, and in some cases even skip sentinel lymph node biopsy. So this paper is all about that less is not necessarily more. It is a propensity matched national analysis on the effect and outcome of sentinel lymph node biopsy omission. So the Choosing Wisely Foundation has recommended against doing routine sentinel lymph node biopsy in select subgroup of patients, that is those patients who are clinically node negative, hormone receptor positive, and those patients who are more than 70 years of age. Now, so they have examined the effect of sentinel lymph node biopsy omission in this population database, and hypothesis that the author hypothesized that the sentinel lymph node might be useful even in this subset of patients. So they have extracted the data from the National Cancer Database from 2012 to 2017, and they have included all the patients with clinical stage of T1 and 0M0, those who were hormone receptor positive and HER2 negative. And to omit the bias, they have done a 1:3 propensity match. And later on, the overall survival was analyzed using multivariable Cox proportional hazard regression. So the total number of patients they have extracted is 14,150, out of which 86%, 86.4%, that is around 12,222 patients underwent sentinel lymph node biopsy, while rest proceeded to, of these 12,000 patients, around 1,545 proceeded to ALND, and 1,397 have further node positive, based on which they received radiation and chemotherapy. So they analyzed what are the factors which are associated with the pathological positive lymph nodes, and they found that the central portion location of the tumor, clinically T1C patients, that is tumor more than 10 millimeter to up to 20 millimeter, and lymphovascular invasion are the factors which affected pathological nodes involvement. And what they did was for reducing the bias, they have done the propensity match so that most of the population are within the standardized range. And so they have generated around 1,903 sentinel lymph node biopsy omission patient, and total overall patient was 5,703 patient for analysis. And what they have found that after match, sentinel lymph node biopsy omission was less likely to receive chemotherapy in significantly less number of patients, and as well as radiotherapy will be significantly affected in these patients. So if the sentinel lymph node biopsy was done, 3% patients were receiving chemotherapy versus 1.1 when it was omitted. Similarly, radiotherapy was received in 60.8% patient versus 28.9% patient when the sentinel lymph node biopsy was omitted. So omitting sentinel lymph node biopsy was resulting in inferior overall survival. So this is the survival graph, and you can actually see the orange line is where the sentinel lymph node biopsy is being omitted, and there is a gap between the overall survival. So to conclude, sentinel lymph node biopsy may even be important in doing in this select subgroup of patient where the Chosen Wisely Foundation have said that it might not impact the overall survival, but they have found that when they apply this over the overall population and did a propensity match, it is affecting the overall population, overall survival. So pathological staging affect decision on adjuvant treatment, and sentinel lymph node biopsy omission is associated with inferior survival. Even in this population, sentinel lymph node biopsy might need to be implemented, especially in patients who have likelihood of nodal involvement. So, still less may not be more in all the population, and we have to be very careful in selecting the patient group for omission of sentinel lymph node biopsy. Thank you.
Thank you, Megha. I would like to thank all the speakers. We are running short of time. What we'll do, we'll just have a quick, maybe the opinions and take-home message from each speaker. The overall theme is on de-escalation, no treatment, or radiotherapy for axillary nodes in a subset of patients, early stage breast cancers with limited axillary burden. So this has to be very clearly conveyed to the audience. So this, I think we have adequate evidence. All our abstracts have shown. So these strategies are appropriate in the context of treating these patients. So I would like to ask one quick message from each presenters regarding your take home based on your abstract for the Indian audience. We'll start with maybe Dr. Kanchan, please. Dr. Kanchan, are you around?
Yes.
Yeah, please.
Thank you.
One quick take home, Dr. Kanchan, based on the
From my
De-escalation.
abstract. Okay, so I think we are all slowly, inching towards doing less, although Megha did speak about less is not always more.
Yes.
But I think in the Indian population now, where most of us are beginning to see early breast cancers, one rule fits all. Indian population, you can't do this. We see more advanced disease. We cannot apply one glove fits all. So that is where an MDT approach in the Indian setting with specialist breast units and a very careful decision making on which patients will definitely benefit from de-escalation. And before any unit moves towards doing de-escalation, analysis of your own data over the past years to understand what is the patient profile that you are seeing is very, very important.
Absolutely.
And I think we are ready to remove our gloves in most instances and just observe. Thank you.
Thank you, Kanchan. That's very pertinent to our situation. Dr. Som is around.
Yeah,
Yes,
Dev.
Dr. Som, please.
I agree with this abstract session was beautiful. The way I put it is very nice, and Gaurav also very beautifully mega analyzed. For Indian scenario, T1, T2, early breast cancer. If you have done an axillary ultrasound and looks to be clinically and radiologically N0, yes, SLNB. Whether you use dual trace ICG doesn't matter. After you have done a validation of 10 to 20 with FNR less than 5%. Yes. Now, if it is a micrometastasis and you are doing a breast conservation, maybe in Indian set of patients, you can omit. Z11, Amaros, macrometastasis, irrespective of BCT and mastectomy, I think we are not at there in Indian scenario. True N0, yes. Micrometastasis, yes. Macro metastasis, Z11, if you want to apply, you have to audit your results 5-year. In your selected setup under wait and watch, you should do. Mastectomy, SLNB positive, very difficult.
Yes.
Macrometastasis, we are still not at there. I think these are there. But what we can take up from sound trial is do a good ultrasound axilla. You may totally omit SLNB if you are positive.
Yes,
Target experience we do in our setup, but it is not a high level evidence. We need to look at it.
Yeah, but the bottom line is, I think most of the centers, the quality of the ultrasound and FNACs, there is highly operator dependent.
Yes.
So how far I think you need to have a very high quality focused ultrasound done by dedicated breast radiologist and a good FNAC, then only you can rely on the axillary staging based only on ultrasound. I think you are absolutely right. I think the bottom line is you need to see your own data, your own patient profile, and your own expertise available at your center. I think that should determine the de-escalation. Dr. Suhani, please.
Yes, I would take it with a pinch of salt to blindly apply the Western data to our patient population. I would say that SLNB is still the standard of care for early breast cancer, node negative tumors, and with micrometastasis. ALND in our setup still remains the standard of care for node positive macrometastasis. And we also have to take the social circumstances and the realities of having a radiation center before we embark onto these trials, and definitely regular audits is the only answer that we can have in the future.
Thank you, Suhani. You also, I think, expressed the similar sentiments. Professor Gaurav, sir, please, your take home.
Thank you. I think I feel that all of us are in sync with the realities in our country. But what I would like to focus on is, and perhaps disseminate this thought to all my brethren in the country, is less is indeed more. Less and more are relative terms. When we are talking in context of the entire country, unfortunately, the standard of care continues to be a prophylactic axillary lymph node dissection across all patients with clinically node negative disease. So those kind of patients need lesser than a standard axillary surgery, which should be either sentinel lymph node biopsy or maybe axillary sampling. And what the abstracts we have discussed today, barring what Som presented, which was an overview of everything, but other than that, we have discussed when we have achieved a certain standard of minimalistic approach to axillary management. So if in that context, I agree with exactly what Kanchan said and with what Suhani said, that there has to be an individualized approach. Patients who have no metastatic nodes or micrometastatic disease alone, and who are going to be otherwise treated with multimodal treatment, including radiation, we can omit axillary resection. patients who have macrometastasis and who have a significant disease burden otherwise should not be offered omission of axillary dissection as yet. The abstract that I presented, Synodar 1 trial, the results are only interim. The follow-up is rather short, and we need more confirmatory data to actually change our practice from axillary dissection for macrometastatic disease to omission of axillary dissection. That is my take.
Thank you, Gaurav. That's very well summarized. Dr. Megha?
Thank you, sir.
Megha, I really liked your abstract because that reflects the real world scenario. The control trials outcomes are totally different. Sometimes they may not reflect the real world outcomes. So I think this abstract is very important. We need to be very careful. SLNB omission showing impact on survival.
So when we talk about de-escalation as a surgeon, I think we should need to understand that breast cancer is a multimodal disease. And we can only be confident, as Dr. Kanchan said and Dr. Swani said, that unless our radiologists are good, our pathologists are good, we act as a team, we have our MDTs, we came out with our own policies, we individualize each patient, we discuss each patient. Until then, I think as a surgeon saying that it's an era of de-escalating and everything, it sounds good, but in reality, it's something different. And again, we left the patient. There's no, as Dr. Swani said, that there may be no radiotherapy facilities, the social circumstances. So we have to look the disease in toto rather than being a surgeon that I could be. So I can't be confident unless my team is good and my team is confident as well. But definitely it's an era of de-escalation, and we should consider all these guidelines which are coming in from the Western data. Although I agree that in blindly extrapolating it would not help, but yes, we should come up with our own solution to our own problems. Thank you,
Megha. I think that's a wonderful sort of I think that shows all the experts, despite the evidence and abstracts, we are on the same page. The bottom line is de-escalation. Yes, we are for it, but you need to contextualize and see your own experience, your own expertise, your own patient population before. Don't jump to de-escalation blindly. So that is the message for take-home message for the audience. Unfortunately, we are running behind time. We are already, I think, 10 minutes past our scheduled time. I would like to thank all the faculty for doing the job, fantastic job on summarizing the abstracts on axillary lymph node management. I would like to close this session. Rohan, anything would you like to add?
No, thank you, sir.
Thank you. Thank you. Thank you, all the faculty, all the delegates. Thank you very much, the organizers. Thank you. We would like to conclude this session, please.
Thank you so much.
Thank you.
Ekta, you can start the next session, please.
Yeah.
Hi, good morning, Dr. Harith.
Hi, morning, everyone. Good morning. Fantastic session. I think we are all in the same boat. As you were talking, I was thinking we are going to repeat this, but I think repetition is important because we need to really bring this practice on ground across the country. So it's going to be very good.
Great, Harith. Thank you.
Yeah.
Ekta
Let us
is
start
here?
the next session. Yeah.
Yes. Ekta, are you around?
Rohan Kandelwal. Yeah.
Yeah, Dr. Rohan, you can set the ball rolling for the next.
Redefining axillary management after neoadjuvant chemotherapy. What does the evidence suggest? Yeah.
Thank you very much, sir. Thank you to the organizers for this opportunity. I'll be talking about refining axillary management after neoadjuvant chemotherapy, what the evidence supports. I think so. In the first session, we've listened to abstracts regarding sentinel lymph node biopsy in upfront surgery and regarding de-escalation of axillary management. This abstract focuses more on SLNB and axillary management after neoadjuvant chemotherapy. This was presented in the San Antonio Breast Cancer Symposium. We all know that axillary lymph node dissection was the standard of care for a long period of time until its role was challenged in the NSA-BP4 trial. And it provided local control and staging information, but this has largely been replaced by sentinel lymph node biopsy, which does the same with considerably less morbidity. So if you look at the roadmap for decreasing the role of ALND, I think so in the previous abstracts, we've already discussed eliminating ALND in node negative patients with negative sentinel lymph nodes. We've spoken about the SYNOD-R1 and the Z11 data, where we can reduce the role of ALND in N0 patients with positive lymph nodes, both micrometastatic and macrometastatic. We've discussed the AMAROS trial where axillary radiotherapy versus ALND was compared, and there were equivalent outcomes with less morbidity. This abstract talks about SLNB and ALND in the context of post-NACT patients. With the improvement in neoadjuvant chemotherapeutic regimes and drugs, the conversion of positive nodes to negative nodes post-NACT is improving, and the PCR rates have also improved over a period of time. This gives us an opportunity to deal with a lot of patients who are node negative post-NACT. Now, when we apply the SLNB concept to these patients, there are some theoretical challenges in these subgroups. One being that scarring can lead to altered drainage. And the second, which all of us are aware of, that there is non-uniform regression of tumor when NACT is given. So these two can lead to an increased false negative rate in the post-NACT setting when SLNB is done. So patient selection when we are going to do SLNB post-NACT is of paramount importance. This can be done in T1, T3 patients who are node negative or clinically node positive, but it is still questionable in patients who have T4 disease, extensive skin involvement, matted lymph nodes, or inflammatory breast cancer. As was previously discussed in the first session, all of us agree that a proper axillary ultrasound should be carried out prior to NACT, and these patients who have indeterminate or suspicious lymph nodes should undergo an FNAC. As Dr. Som mentioned, that they've also started routinely clipping these lymph nodes, which can be useful for targeted axillary clearance post-NACT as well. In a meta-analysis of 16 studies in patients who had node negative disease to start with when neoadjuvant chemotherapy was done, it was seen that the identification rate of SLNB was 96% and the false negative rate was 6%. So SLNB is technically feasible in patients who are starting off with a clinically node negative disease and receiving neoadjuvant chemotherapy. In these 4 prospective trials, in patients who had node positive disease to start off with, it was seen that the FNR was much higher as compared to the node negative group. And in 3 of the 4 trials, it was more than 10%. But what was also seen was that if multiple sentinel lymph nodes were removed, the FNR came down to a more acceptable range to less than 10%. A meta-analysis of 19 studies in patients who had nodal involvement and then received neoadjuvant chemotherapy revealed that the FNR was 13% as compared to 6% in the node negative group, and the identification rate was 91%. So SLNB is feasible. It is technically feasible and a valid alternative to ALND, but appropriate patient selection and improvement in techniques can improve the FNR and the identification rate in this population. An unplanned subgroup analysis of the Z1071 trial, where the lymph nodes were clipped, revealed that if the clipped lymph nodes were retrieved, then the FNR came down to 6.8%. Whereas if no clipping was done, the FNR was as high as 13.4 to 14.3%.
So Dr. Rohan, your time is getting over. It's already over actually. So can you summarize?
Yeah. Yes, please. Yes. The MD Anderson data showed that if a clip node and sentinel lymph node is done together, then the false negative rate comes down to 1.4%. And a very important message here was that the clip node was not the sentinel lymph node in 23% of the patients, which is why an SLN should be added. Now, there are various ways to mark these nodes. One of them is the radioactive seed placement technique. In the research trial, the false negative rates for removing the clipped lymph node was 3.47. And the MARI protocol, which used the same method, the false negative rates were 7%. The studies which have been done for marked lymph nodes and targeted axillary clearance show that if marked axillary lymph nodes are removed, the FNR rate is 6.28. And if targeted axillary clearance is done, the FNR is 5.16, which is in the acceptable range. So to optimize SLNB performance post NACT, appropriate patient selection should be done. Dual lymphatic mapping should be done. More than 2 lymph nodes should be removed. And if possible, clip localization and targeted axillary clearance should be done. The MSKCC experience showed that even if there's low burden disease in the axilla while doing SLNB, patients should land up with an axillary lymph node dissection. The Alliance trial is going to challenge this, where one of the arms post NACT, even if there's positive lymph nodes, there will be no further axillary surgery done. So the results of this trial will be awaited. So to conclude, sentinel lymph node biopsy is feasible post SLNB, but proper patient selection and optimal techniques should be followed to reduce the false negative rates. And clipped lymph nodes and targeted axillary clearance are solutions to that, which can bring down the false negative rate. Thank you very much.
Thank you, Rohan. Thank you very much. Now I'll just quickly call Dr. Mihir to talk about is less or more axillary surgery needed in genomic era. So how do we leverage the data from genomic era to tailor our surgeries? They were tailoring chemos and now for surgery. So Dr. Mihir is there?
Good morning. Can you hear me?
Yeah.
Thank you.
Please.
And can you see my presentation as well?
Not yet, but it will come, I think.
Genomic era, and I will try my best to keep on time. No conflicts of interest to declare. We have seen significant changes in axillary surgery in the past couple of decades. It was a historical teaching to do axillary lymph node dissection in all patients with positive lymph nodes. However, we need to see whether it has any impact on survival, local control, staging, or determination of future systemic therapy. Looking at survival, the classical NSABP B04 and the more recent ACOSOC Z11 and AMAROS trials have shown that there is no impact of extensive axillary lymph node dissection on survival. However, these trials did have their limitations. I will not go into the details. The latter two trials were also highly underpowered. Before we go at looking at local control, let us look at incidence of pathological node positivity in clinically N0 patients. MSKCC data on clinically node negative patients on physical examination only showed that 25 to 35% of patients did have positive nodes. The incidence was higher in HER2 positive patients. This has been reflected in other studies. However, when we add ultrasound examination to physical examination, the incidence goes down to 8.6 to about 14%. And notably, the incidence of more than 2 nodes, as reported in the INSEMA trial, in postmenopausal age group, if the primary is T1 or T2, is less than 2%. It is this subgroup which has been discussed in more detail and where omission of sentinel node biopsy has been thought of. Now, the IBC-SG trial randomized clinically node negative patients into axillary lymph node dissection versus no dissection, and there were comparable axillary recurrences in the both arms. However, only 28% of the patients in the trial in each arm had node positive disease. Also, there is some extrapolation from the CALGB 9343 data that randomized patients after a lumpectomy into tamoxifen versus no tamoxifen, tamoxifen versus tamoxifen plus radiation therapy, and a good number of patients had axillary lymph node dissection. However, this was not a primary arm and it's only extrapolation of data. Based on these trials, it has been concluded that axillary lymph node dissection or extensive axillary surgery does not provide survival or local control advantage. It may help, though, in staging or determining future therapy. So the question remains, can we completely avoid or omit axillary surgery in some patients, or we need to increase the use of axillary lymph node dissection to precisely tailor therapy? Let's have a look at node positive, hormone receptor positive patients that were included in the RxPonder trial. They randomized patients with 1 to 3 nodes positive and a recurrence score of less than or equal to 25 to chemotherapy and endocrine therapy versus endocrine therapy alone. On stratifying based on their menopausal status, there was a benefit of chemotherapy in node positive premenopausal patients versus postmenopausal patients. And hence, the information that we get from the lymph nodes is important in the premenopausal age group. Therefore, we cannot omit any axillary staging in this age group. However, in the postmenopausal age group, it has been argued that we can omit SLNB because it is only the recurrence score that is a determinant of future systemic therapy. Also, interestingly, in the RxPonder trial, about 37% of patients had only sentinel lymph node biopsy, and chemotherapy showed no advantage with more number of nodes being positive. Let's have a look at briefly look at Monarch E trial as well, where 1 to 3 node positive patients with bad prognostic factors were included, and axillary lymph node dissection should be performed in this set of patients. How about HER2 positive and triple negative breast cancer patients? Is there any subgroup where we can withhold doing sentinel lymph node biopsy? In HER2 positive and triple negative breast cancers, all lymph node positive patients should be treated with neoadjuvant chemotherapy, and post NSAT SLNB is the minimum that is required in these patients, if not ALND. In stage 1 HER2, in T1 HER2 positive patients, again, information on the node is important as it will change the chemotherapy regime in a node positive patient. However, in triple negative patients, there may be some role of omitting sentinel node biopsy in future. The most important question is a decision about adjuvant radiation therapy after mastectomy in patients who are node positive, and we need this information in our adjuvant treatment planning. Similarly, in breast conserving therapy, where we are treating patients with adjuvant radiation therapy to the axilla, the lymph node, the information that we get from SLNB is important, and hence we cannot omit SLNB primarily because of this region. Secondly, the morbidity of SLNB is much less than the morbidity of giving axillary radiation therapy. So based on these, the author has concluded that in small node negative patients, SLNB may not be needed for local control. There are certain criteria where SLNB is needed, and these are hormone receptor premenopausal patients, post-chemotherapy patients, triple negative cancers less than 0.5 centimeters, and stage T1 HER2 positive cancers. She has also concluded that in majority of the breast cancer patients, nodal status is not the determinant or not the only determinant of systemic therapy. However, nodal metastases still remain the primary determinant for post-surgery radiation therapy. Taking into consideration Indian perspective, if we have to go back to the two questions again, can we possibly omit or avoid axillary dissection in eligible patients? My answer is yes. And can we omit sentinel node biopsy as of today in any selected subgroup of patients? My answer is no, because sentinel node biopsy provides important staging and prognostic information. It has minimal morbidity, and it is a determinant of future systemic therapy in most of the patients. This will be my approach to treating the axilla today. We have to include ultrasound scan examinations for staging of the axilla, as it will reduce the pathological positivity rate after after sentinel node biopsy, and that's where I will conclude. Thank you.
Thank you, Dr. Meher. Thank you very much. Now we go on to, we'll have few questions for the panel later on. I'll request Dr. Neha to please present intelligent vacuum-assisted breast biopsy to identify breast cancer patients with pathologically complete response after neoadjuvant chemotherapy. And they're trying to omit surgery completely. So,
thank you,
Dr.
Harit Chaturvedi sir, and thank you, team SABCS, for giving me this opportunity. So this is a very interesting abstract, and kudos to SABCS team for picking the small poster from the lot. This is the abstract is intelligent vacuum assisted biopsy to identify breast cancer patients with pathological complete response after neoadjuvant systemic treatment for omission of breast and axillary surgery. So I looked up the primary author, Andre Fob here, and he is attached to Heidelberg University Hospital, Germany, and MD Anderson Cancer Center. And he's got a keen interest in artificial intelligence and breast cancer research, and has a lot of work going on. So a little bit of background, we all know that neoadjuvant systemic therapy does elicit pathological complete response anywhere between 40 to 70%, depending on the IHC. And these patients would probably benefit from no surgery, no breast surgery. And breast surgery is an overtreatment in them, but we do not know how to select this patient group. Currently, no approach, be it imaging guided, vacuum assisted biopsy only, has accurately detected and excluded residual disease. All of these have had a false negative rate of more than 10%. So now what have they done? They have taken help of machine. So machine learning algorithm was what they have done. They have trained, tested, and validated this machine learning algorithm on their previous trial, that is on the responder trial and subsequent trials, by putting patient imaging, tumor, and VAB variables, and then tried to detect whether the machine is able to detect residual cancer properly. So the algorithm, what they've used is XGBoost or extreme gradient tree boosting. I'll tell about it later. And they have tested, first they have had a developer set where they have tested 318 women with T1 to T3 disease, node positive or negative, and who could potentially respond to chemo. So HER2 positive, triple negative, or luminal B type. They have 10-fold cross-validated it for developing the algorithm, and again validated it on another independent trial, which was of 45 women. Then they have compared the histopathology with the final surgical specimen with the algorithm result. The primary outcome was false negative rate compared to surgery and specificity. So a little bit about what XGBoost is. So this is a decision tree based algorithm where there are multiple options which the algorithm can choose. Further, in the parallel tree choosing there, and then they have selected subsets from that, build up a random forest, done boosting, that is minimized error, again done gradient boosting, again minimizing error, again done extreme gradient boosting, that is tree pruning, minimizing errors, handled missing values, and finally developed the algorithm. So this is XGBoost for you. There's a lot to talk about it, but time is less. So if you just look at it, what XGBoost has done, so it has allotted impact or value to specific variables. For example, if you look, then cancer cell in VAB has a very high impact value. Obviously, that will be, and like a progesterone receptor or VAB size has a much lesser value. So finally, the result that they got in the development and the validation set was pretty good. The negative rate was 5.2 and 0% in the different sets, with a specificity between 37 to 40%. If we compare it to methods of imaging alone, VAB alone, or imaging plus VAB, we see that their false negative was very high, 24, 28, 12%, whereas for intelligent VAB, it is 0 to 5.2%. However, the specificity is 40%. So the authors have concluded that intelligent VAB can reliably exclude residual disease after neoadjuvant systemic therapy, and this can be evaluated in future trial for omission of breast and axillary surgery for exceptional responders. My take would be definitely this can be a basis for a randomized control trial to see further outcome data. However, if we do find a randomized control trial, what are we doing with radiation? Because when we conserve breast, we do add radiation to non-operated breast. Another thing is, if you see that the specificity is quite low. So out of 100 cases which have had a pathological complete response, they're able to pick up only 40. So, there's a very stringent criteria. They have a very high threshold of rejection, and that is why probably their false negative is so low. So can we expand criteria for patient selection to improve the specificity? What can we add? Can we add circulating tumor cells? Can we do subset analysis by IHC? If we look at practical world, again, availability of VAB, training, skill, all those are things which have to be looked into. A little bit of food of thought, we are seeing something very amazing here, that artificial intelligence is helping us pick up cases which have responded excellently. So can we apply this to metastatic disease? On one end, we are looking at oligometastatic disease and local therapy, whereas other end, we are looking at local disease without local therapy. Can we find a middle ground? And again, we have all had patients who have been metastatic disease and have responded for long term, 5 years, 6 years. Can we reclassify them as a better prognostic variable? Can we check circulating tumor cells, add it to algorithm and do something about it? So I think artificial intelligence has a long way to go, and there's still a lot coming up.
Thank you. Thank you, Dr. Neha. And I think this will invoke a lot of questions, and certainly has given a lot of thought to people wherever they're listening. But we'll have a few questions on the panel. I request Dr. Vaishali to present her paper, a multicentric prospective study to predict pathological complete response by WAB based on MRI and ultrasound. Dr. Vaishali?
Yeah.
Yeah.
Good morning, sir.
Morning.
I hope my slides are visible and I'm audible.
Visible, and you're audible. Yeah.
So thank you to the organizers for this opportunity. My abstract is a minimally invasive method of prediction of pathological complete response after neoadjuvant chemotherapy, a study from Japan. So we all know that there is no accurate way of knowing pathological complete response other than surgery in patients who respond well, despite and we understand the fact that there is a variable, response pattern. It could be centripetal or it could be Swiss cheese pattern. So the objective of this study was to assess the accuracy of clinical complete response by vacuum-assisted breast biopsy plus MRI and ultrasound findings for each subtype of primary breast cancer patients with clinical complete response after neoadjuvant chemotherapy. This study was conducted in 5 centers in Japan, and they had included patients with clinically T1 to T3 tumors and any node status, and M0 patients who had been found to have clinical complete response by clinical assessment as well as by imaging, that is MRI plus second look ultrasound. And all these patients received anthracycline plus taxane-based chemotherapy, and HER2 positive patients received anti-HER2 agent. The primary outcome of this study was negative predictive value, false negative rate for MRI as well as ultrasound, and for a combination of WAB and imaging. And they had done this study for 3 different subtype of breast cancer, that is triple negative, triple positive, and HER2 positive. So 96 eligible patients were included in the trial, and 8 were excluded for some reasons. So overall, 88 patients were included. So these 88 patients underwent a vacuum-assisted breast biopsy by a 10-gauge needle, and 5 cores were obtained for all these patients. And the pathological complete response was defined as no evidence of residual invasive or in situ carcinoma in the studied specimen. So in this cohort, the median age of the patients was 51 years, and nearly 67% of the patients were in stage 2. Nearly 67% patients underwent sentinel node biopsy, and more than 63% patients underwent sentinel lymph node biopsy. In the WAB results, 79.5% patients were found to have no residual tumor. However, in the surgical pathology specimen, the number of patients with residual invasive as well as in situ tumors were found to be nearly 50%. So there was a big discrepancy. So when they studied the accuracy of radiological assessment for clinical T0 and TIS, it was found that the negative predictive value of imaging, only imaging, that is MRI plus ultrasound, for no residual invasive and in situ disease ranged from 65.5% to 84%. The highest negative predictive value was found for HER2 positive patients. When they added WAB to the imaging findings, it was found that overall negative predictive value for all the patients of this cohort was 67.1%, but the false negative rate was very high, that is 56.1%. The lowest false negative rate was found for triple positive breast cancer, and the negative predictive value ranged from 63.9% to 72%. So for patients who had only for patients with only invasive breast cancer, the VAB plus imaging findings did not have any significant improvement in terms of finding only the invasive component. So negative predictive value was found to be 72.7% for, again, triple positive breast cancer, and false negative rate was low for triple positive breast cancer. When they studied a subgroup of patients who had clip marker insertion, the performance was slightly better. The negative predictive value improved to 90%, but false negative rate was still high to 33.3%. Then they studied another trials which had actually done similar assessments, and it was found that the negative predictive value and false negative rates were variable, although they were not, only one trial found that the false negative rate was as low as 5%, but in other trials the false negative rates were very, very high. So the authors concluded that VAB plus radiological findings also were not accurate enough to predict pathological complete response in any subtype of the breast cancer. And this could not support to eliminate surgery by VAB for patients who achieved clinical complete response after neoadjuvant chemotherapy. So although this trial was very nicely designed, it was a prospectively designed trial, highly selected group of patients were taken into this study based on the MRI and ultrasound findings, and a very unified procedure of biopsy was actually adopted in this trial. The number of patients in this study were relatively small, and despite all these proper design, they could not find any accurate results. So they and these were the trials on which the study was actually based. These were some of the ongoing and the previously concluded trials. So since they could not find any accuracy in adding VAB to the MRI and ultrasound finding, my take home is that although the modern systemic therapy predicts pathological complete response in a certain select group of patients nearly to the tune of 60%, surgery merely serves to confirm pathological complete response, but it is at the cost of morbidity and psychological burden. However, the accurate identification of pathological complete response without surgery is still a challenge, and we do not know what is the accurate way of predicting a false negative rate of less than 5%, which may predict a good pathological complete response reliably enough to avoid surgery. So I would say that in the current times, when we do not have any randomized evidence, we still cannot say that the surgeon's job is over. And in patients who although have pathological complete response on VAB, I would still say that surgery is mandatory. Thank you.
Thank you. Thank you, Dr. Vaishali. We come to the last abstract for this session, and that is from Dr. Chitresh Sharma. And we will have a couple of questions for the panel subsequently. Dr. Chitresh, you can upload your slides. Thank you, Vaishali, for this.
Thank you, sir.
Thank you, sir.
Are my slides visible, sir? My screen is visible.
Your screen is visible, not the slides.
Okay.
Yeah.
So, thank you, sir, and thank you, organizers, for providing me the opportunity to present an abstract which was presented in the SABCS, and the topic was the safety of conservative surgery with accelerated partial breast re-irradiation for isolated skeletal breast cancer recurrences. So the salvage mastectomy is practiced as a standard of care after the isolated or the breast tumor recurrences. This is practiced all over the world, including India. But when we look in the literature and try to find out that is there any solid data or literature which can support that this salvage mastectomy is better than the conservative approach, the answer is no. So this study analyzed the oncological outcomes after repeated breast conservative surgery or therapy, and this study will ignite us and make us to think that can we redo the breast conservation surgery? Can we redo the breast conservation surgery? And in the study, it was done between the year 2014 and 2020. So 35 patients were selected for second BCT, and this study was done in Spain. And the inclusion criteria were age more than 50 years, and the time from the primary treatment or breast conservation more than 48 months. So after 4 years almost, they have taken the isolated breast tumor recurrence. They excluded the multicentric and multifocal tumors, and they have taken the tumor recurrences which were sizing less than 2 centimeters and where there was no primary major radiotherapy toxicity, so they can re-irradiate the breast. And the feasibility of breast conservation surgery as far as the breast volume or excision volume was considered, and after a proper informed consent, they have included in the 35 patients were included. The median age was 65 years, and the median time to recurrence was 154 months. Most of the time, more than 85%, the recurrence was invasive carcinoma, and they have done the wide local excision and accelerated partial breast re-irradiation. There were 3 TNBC patients who received the adjuvant chemotherapy, and out of 5 HER2 positive, 4 were received chemotherapy and trastuzumab. All the hormone positive patients received adjuvant endocrine therapy. After the median follow-up of 37 months, there were 4 relapses, and one was the after the second IBTR. And the metastatic progressive diseases were both found to have a luminal B type. There were 2 deaths not related to the breast cancer were reported in this trial. And after 5 years, the regional free survival was 82%, metastatic free survival was 84%, and the overall survival was 93% respectively. So the survival was pretty good after the second breast conservative therapy. The invasive ductal carcinoma was the most common histology, 77%. And the most of the patients were hormone positive. The recurrences were around half were in the same quadrant and half were in the different quadrant. And the luminal A and B was the most common type of immunohistochemical type. So they have concluded that conservative treatment with breast conservative surgery and accelerated partial breast re-irradiation for isolated breast tumor recurrences after a breast conservative therapy seems a feasible technique as an alternative to mastectomy, and the second local recurrences and the overall survival after the second therapy similar to the rates described as for salvage mastectomy. So in this patient cohort, the immunological subtype, tumor, and poor prognostic positive markers did not show any an increase in the local recurrence rate, though the sample size were very small. So as far as the Indian perspective and take home message for us is, we also do come across the isolated breast tumor recurrences, and most of the time we plan for salvage mastectomy. So after discussing this trial or this study, we can also think of offering the patient the second breast conservative therapy if the patient is keen for breast conservation, and provided the recurrence is late after 4 years, the recurrence is small, less than 2 centimeters. So
thank you.
And we should also critically analyze our results. Thank you, sir. Thank you very much.
Thank you very much. Thank you. I think we'll quickly go through the questions for the panelists because we are already running late. So do we have Dr. Commander Shaida with us right now? Because those who have not participated, I will request them first. I can see Sajjan. So I'll start with Sajjan and then we can. So Sajjan, my thought was that surgery is the mainstay of curative intent treatment in breast cancer, local regional breast cancer. And all this is directed towards minimizing surgery. Do you think it's a fair thought? And what percentage of your patients are eligible for genomic studies and repeated imaging and close follow-up and surveillance, and your ecosystem where you work, how the team collaborates? So how ready are we to deliver this in our practice? Dr. Sajjan?
Sir, I agree with you both. So I think the surgeons who are actually pushing the wall towards less and less surgery, and probably there might be a time when there'll be some certain patients which might require no surgery, sir. So that's one thing which I agree with. And there have been really interesting studies. Only issue is that because of the fear of missing certain patients who might have an invasive disease, if we don't go for surgery, I think that's the reason why we are still having surgery, especially early breast cancers, because I feel, sir, 40 to 50% of these patients will become eligible for no surgeries in the future, probably 5 years from now. Now, that will depend upon a lot of radiomics as well as AI as well as genomics, sir. So once we have more confidence, because we have moved from, it took 100 years for us to move from radical mastectomy to MRM, sir. So it will take another 10 years for us to move from minimal invasive surgery to no surgery, sir. That's my take,
Fantastic,
sir.
fantastic. I think you have echoed very much the sentiment of what we all feel, that minimal surgery is the way to go. It has to be adopted with caution, integrating all the facilities, all the knowledge, putting the whole ecosystem together in place. And I think together our goal is to have best quality of life and best outcome without compromising on survival. So thank you very much for that. Any other thought you want to share? Because you are the only odd person in this group, the only medical oncologist. All of us are from the sane world otherwise. Yeah.
Sir, I think we all have been working together as team, and working as a team, having the system of consulting each other and respecting each other is it's the way to go for patients to feel to get the best treatment, sir. That's the other message, sir.
Thank you for that. Thank you so much. Commander Shaida is there. Otherwise, I'll request Rohan for his thoughts on axillary surgery after NSCT. First, Commander Shaida. Let me check if he's around. He's not there, I think. Okay. So, Rohan, may I have your thoughts on, so for which subset of patients in your practice will you start shifting towards limiting surgery in NSCT, refining surgery in NSCT? And have you started in your practice, number one? And number two, what is your acceptable false negative rate?
So, yes, sir. In post-NSCT patients, I have been doing sentinel lymph node biopsies, but as I mentioned, the patient selection needs to be appropriate. So this is predominantly that group, which is a large operable breast cancer group, which is HER2 positive or triple negative, who are receiving chemotherapy upfront. These group of patients, by doing a prior ultrasound before NSCT and doing an FNAC, if they're node negative at that time, then these subgroup of patients, I'm definitely doing sentinel lymph node biopsies. Very recently, I've started, we've started clipping the lymph nodes as well. So I would need more time to comment on that in future. For positive lymph nodes, we've started clipping, but maybe next year we'll be able to talk about that data. But whenever post NSCT, I'm doing sentinel lymph node biopsy, I'm always using a dual marker technique. And my practice usually is to remove 3 or more lymph nodes in these patients so that the FNR comes down. And the FNR which we target is less than 4% is what my practice is.
Fantastic. So I think very important clue you have given, that start with something which is more safe. Where it was starting early on, you had a node negative disease, and then gradually as you get confidence, have numbers, and then you practice this. So as you mentioned that the risk of altered fibrosis leading to altered LND, sentinel node, or for that matter, having sentinel node negative and a positive node elsewhere, all these things should be kept in mind. So any adoption of new thoughts, new science, new technology should be gradual, cautious, and with the growth of the team. Thank you. Anything else you want to share, Rohan?
No, sir. Thank you very much.
Thank you. Thank you. Dr. Mihir, yeah.
Yes.
Your thoughts on needed in the genomic era as axillary surgery is getting tamed. So I'll have a specific question for you. In a fit 73-year-old, screen detected, T1C node negative, receptor positive, HER2 negative, will you offer this patient sentinel node? Will you recommend, or willing to live with the uncertainty in Monica Moro's terms?
Yes. So excellent question. This is the exact group of patients which she has recommended where we can omit sentinel node biopsy. Now, going back to the INSEMA trial, which included more than 1,000 patients with similar subset of patients, they showed that the chance of macrometastasis was about 14%, and the chance of having more than 2 nodes is about 2%. So, and till date, I don't think we have omitted sentinel node biopsy in any of these patients. So if today and these set of patients will be probably treated by adjuvant endocrine therapy. So the risk is leaving behind 1 or 2 macrometastases in 1 out of 6 to 1 out of 7 patients and treating them with endocrine treatment in future, whether it is safe leaving behind 2 positive nodes in the axilla or no, it is not known. I agree that if I'm doing a sentinel node biopsy, which is a very less morbid procedure, it is essentially a lymph node biopsy. And if I get 1 out of 3 sentinel node positive patients, it is safe to not do an axillary lymph node dissection because chances of having additional positive nodes are only 2%. If I get 3 out of 3 sentinel node positive in these cases, then axillary node dissection is recommended. But at this stage, based on the available data, my answer is still no. I will still do an axillary lymph node.
Any axilla?
No, I will not observe any axilla. Especially in the Indian context, even in this group of patients, because it is a very less morbid procedure and it gives me the information that I need today.
Okay, got your point. So any other thought you want to share related to your abstract?
Based on the overall management of axilla, we are going towards doing less in the axilla. We should encourage patient participation in clinical trials, especially in the post-neoadjuvant chemotherapy SLNB settings in India. And there have been recently concluded trials from the UK that are looking at further axillary management in sentinel node positive patients in the upfront setting. And once the results are out, we'll be in a better position to treat our patients. Thank you.
Thank you for sharing that. Dr. Neha, I thought this was the most out of the box presentation or a thought which was shared with all of us. So my question to you is that this intelligent AI usage with WAB and ML, what is it actually doing? I think you put a lot of data together, and how is it putting together? And this is for both the primary and the axilla too?
So, sir, the full paper is still not available, but whatever I could understand from the abstract, it is for the primary and the axilla too. I would like to understand how they did WAB in axilla.
I was also not able to understand. That is why I thought I'll ask you.
I did a little bit of search and I couldn't find that answer, but I think it is for axilla too, because in the abstract they have mentioned axilla also.
Yeah.
Yeah.
So would you accept this for a 50-year-old early T2N0 HER2 positive disease to start with?
Sir, if I would accept it for any group, it would be that probably.
That group.
But whether I would accept it based on current evidence is a question. Definitely more data, maybe a randomized controlled trial to see outcome data.
So maybe you will start a study in our scenario.
But it will be great.
And you will inspire few of us also to do it, the old ones to do it.
Sir, I'm sure that it can very well be done in India, because India is a place where artificial intelligence can be developed well.
Actually,
so why not, sir? Why not?
As I was going through these abstracts, I was realizing that the time has come that we should be actually coming out with these thoughts.
Yes, sir. Yes.
So excellent, I think. Thank you very much. Thank you. Anything you want to say on about any of these?
Sir, one comment, sir. What Dr. Sajjan Purohit said, that it took us 100 years to reach from radical mastectomy to MRM, but it did not take us so long to go from MRM to BCS and further. So I think we are running faster than before.
That is what he also said. It should take not more than 10 years. He made a very valid point.
Yeah, it is going to come in 5 years, sir. What I said.
You're pulling it further. Great.
I think we should all be sensitized towards it.
Absolutely. Thank you so much. And for that, I think we must thank the organizers to bring all this data together. So Dr. Vaishali.
Yes, sir.
So they have said MRI and ultrasound assessment post chemotherapy. Would you consider X-ray mammography also before thinking of WAB? Or what is the radiological assessment which gives the idea of in situ disease? That is something which was quite confusing. And how they come to us.
So
and
basically,
they also mentioned that CLIP marked group was a separate group. I am clubbing 3 questions together for questions.
Yes, sir.
CLIP marks. So what is that group which is without CLIP?
So those patients, because this study included even T3 and any N disease, so probably those patients who were not going to be taken up for conservation, they did not clip those patients. So that is one thing. The other thing is that although these patients who had advanced disease were relatively less, but the clipped patients were those patients in whom the VAP could retrieve the clip. There were certain patients who had been clipped, but the VAP could not retrieve those clips. They were excluded. So that is the other thing. The first question which you asked about addition of the X-ray mammography, if the patient has had microcalcification, which is probably very well seen on X-ray mammography, then in those patients, probably I'll consider adding X-ray mammography before going for VAP. And in this particular study, there was a prior study only considering the feasibility of or predicting the accuracy of MRI plus second ultrasound by similar authors. There they had mentioned that they took up those patients who had a residual disease of only 0.5 centimeter or less, and where the lesion to background enhancement ratio was less than 1.6. Those patients were vascularity after neoadjuvant chemotherapy were considered to be harboring in situ component.
Got
so
it.
that was
Anything you want to add, Vaishali, regarding anything else in this session?
Sir, as Dr. Sajjan and Dr. Neha mentioned, probably in 10 years time when the results are available, I would be happy to retire.
Not that. I'm not happy to retire, but nevertheless, let's move to the next topic. So PCS after recurrence, I think it is worth the risk, and I think in a properly selected cases, as you pointed out. So I understood that the favorable tumor with good, all that works very well. If all is going well, would you offer this to your patients? Number one. And number two, what do you do if you have a multifocal disease? So what is it's coming is, are you practicing in breast conservation multifocal disease or not yet?
Sir, truly speaking, not yet. And I have not practiced the second breast conservative surgery till date. So after studying this article, at least we can think of if we can have a low risk tumor, as this article mentioned, that the elderly patient luminal A and B, and the recurrence time was more than 4 years. It was isolated, it was unifocal, it was less than 2 centimeters. So we are trying the de-escalation in every possible procedure, chemotherapy, axilla. So we should also try. And the bottom line is your patient should be convinced for the second breast conservation, because this is the most important thing, that you cannot I mean, we have explained in the first setting also, but second time making the patient convinced for the second breast conservation is really difficult, and I think we will try.
Very, very practical tip, yeah. But nevertheless, there are people who ask for it. Thank you very much. Thank you. Any thoughts you want to share about anything else in this session?
No, sir.
Thank you so much. Thank you, organizers. Please, we can move on to the next session.
I would like to invite Dr. Diptendra Sarkar. Sir, can you please moderate the next session? Thank you.
Thank you, Pooja. And I will go straight to our first speaker, Dr. Vedant Kabra. Vedant doesn't need any introduction. Vedant, if you could start sharing your slides. And he's the Principal Director, Department of Surgical Oncology, Fortis Memorial Research Institute, Gurugram, Fortis Healthcare, Delhi. So Vedant, and I understand this session is mostly for stage 4 and the role of surgeons as such. So Vedant, the podium is yours.
Thank you, Dr. Sarkar, and thank you, SABCS team, for inviting me here. So as we all know, locoregional therapy in metastatic breast cancer is still debated. And retrospective studies as early as early 2000, especially the large study by Seema Khan et al., did suggest significant survival benefit
but they have not been universally replicated in subsequent randomized trials. There have been controversial results. So in this study, the authors have sought to determine the national trends in surgical resection and other therapies for metastatic breast cancer. This is a systematic review published in 2011, and you can see Seema Khan's study is there with very good significance level, and has shown that surgery with margin negative resection does improve survival, and the survival improvement in various studies ranged from 29 to 50%, which is quite a huge improvement. Another meta-analysis came in year 2020, and the authors suggested that this therapeutic option should be considered in selected patients after a careful MDT discussion. There are a host of randomized trials, some of them completed but without completing the planned accrual, and some of them are ongoing also. So the methods that were used for this study, they selected more than 87,000 women with de novo stage 4 breast cancer of ductal, lobular, or metaplastic histology from 2004 to 2017. And they studied the trends over the time for the rate of breast cancer surgery in these patients. They also studied the receipt of palliative care in these group of patients. And finally, they have suggested certain predictors of breast surgery based on uni and multivariate analysis. So in the results, this is the trend of breast cancer surgery over the years from 2004 to 17, and you can say there is a decline. Overall, it peaked in 2009 when 37% of the patients, this is the bold blue line at the bottom side of the curve, 37% were subjected to surgery. It declined to 18% by the year 2017. If you see the largest decline, it took place in the HR positive, HER2 negative group, and that's the thin blue line at the top. It peaked in 2019 when 70% of them underwent surgery and came down to only 15% in 2017. Now, seeing the women who received systemic therapy prior to surgery, which were around 12,000 women, they found that the median duration between the beginning of chemotherapy or systemic therapy and surgery was 140 days at the beginning of the study in year 2004, and it increased to 167 days by the end of the surgery. And if you see what combinations were utilized over time, then in 2004, systemic therapy alone was used in nearly half of the patients, and locoregional therapy with or without systemic therapy was used in nearly 37% of patients, so not a huge difference. But by 2017, 70%, nearly 70%, 69% actually, received only systemic therapy, and locoregional therapy was utilized along with systemic therapy only in 20% patients. If we see the use of palliative care, again, quite a dismal figure. Only 21% of the patients were offered palliative care. And if we predict the factors based on this study, so the increased odds of breast surgery were in patients with triple negative tumor, lobular or metaplastic histology, larger tumor size, poorly differentiated tumors, those who received some kind of other therapy like radiation, chemo, or endocrine, probably they responded and then they were subjected, and isolated lung or liver mets. However, the decreased odds were diagnosis after 2013, and that is when the randomized trials had already started pouring in, increased age, black race, and lack of insurance for obvious reasons. So the authors concluded that the rates of locoregional therapy for stage 4 breast cancer have decreased over this study period, according to the data that they have analyzed. And they suggest that this is in response to the RCT findings, and the providers at Commission on Cancer Accredited Hospitals are more selective about who will be offered surgical resection as a result of these RCT findings. They have said that palliative care is either offered at a low rate or it is underreported in the National Cancer Database. My takeaways are that this is a retrospective study and has not qualified the metastatic disease of the whole population which has been analyzed. So the proportion of oligometastatic disease, which actually is more suitable for locoregional therapy, is unlikely to be very high in this population. Decreasing trend actually is not a very surprising finding, because with RCTs, there is more rationalization of selection criteria. And we know that all the randomized data is not supporting surgery for all the patients. However, what is surprising in this study is odds of receiving surgery was higher in biologically unfavorable group, which is at variance to the current practice that most of us follow, for oligometastatic disease. Yes, more effective systemic treatment actually helps both the causes. Those who are supporting systemic treatment only say that since it is more effective now, we should omit surgery or locoregional therapy. And those who propagate locoregional therapy say if it is a better systemic therapy, then let us supplement it by at least having a locoregional control and giving them better locoregional symptomatic control as well as possibly a better survival. But in carefully selected patients, what I feel, especially if they're younger with oligometastatic disease, HR positive or even HER2 positive who can afford to receive anti-HER2 therapy, locoregional disease has a role. And ongoing as well as future RCTs probably will put this debate to rest. Palliative or supportive care must be offered to all metastatic patients as well as earlier in the course of disease. And I would go one step ahead to say that supportive care should be offered even in earlier stages of disease because there are many problems associated with the disease as well as treatment which need to be tackled. Thank you very much.
Thank you, Dr. Vedant. And we take for the questions would be at the end of the session. I move on to Dr. Shaloka Joshi. And if I could invite Dr. Joshi to please start sharing your slide. She's a professor and surgeon, Tata Memorial Center, Mumbai. And may I request Dr. Joshi to start her presentation, please.
Yes, thank you, sir. So very good morning to everyone. I'm given the task of discussing 5 abstracts which are involving surgical omission in breast cancer across various aspects of breast cancer. A lot of it has already been discussed, so I will try and run through those abstracts which are already discussed. So these are the 5 abstracts and I have about just a minute per abstract. So coming to the first, which is Hodgkin disease and association of breast cancer. Survivors of Hodgkin's lymphoma are at an increased risk of developing breast cancer with an absolute lifetime risk of around 5.75%. So in this year retrospective analysis of over 30 years, they identified 295 women who developed breast cancer after being survivors of Hodgkin's lymphoma. 90% of them were unilateral and 17% women had breast conservation surgery. 40% patients had bilateral mastectomy. So when they looked at the incidence of contralateral breast cancer risk, it was 30% at 15 years. And they concluded this was as high as some of the BRCA1 and 2 mutated patients. So the take-home message from this is that you need to, as the guidelines are already in place, we need to offer MRI mammography surveillance in childhood cancer survivors, especially those who have received radiation therapy. Surgical discussion should include mastectomy as probably the preferred choice. And we should discuss contralateral prophylactic mastectomy with the patient as well. The second one is what Dr. Vedant Kabra has already described, surgery in stage 4 breast cancer and the trends in the National Cancer Database. Not going into much detail as he's rightly presented to us that it is a decreasing trend and the incidence of surgery has really gone down from 2004 to 2017. And the largest decline is in hormone receptor positive, older, frailer patients. However, what we still don't know is how to select patients who might still benefit from surgery in stage 4. So this is another database, again an NCDB database analysis of a slightly different time period, which did show a survival advantage of offering surgery and radiation therapy along with systemic therapy. However, they also said that chemotherapy should be considered before starting or before offering locoregional treatment to patients, suggesting that there would be a selection bias here. So randomized control trials have shown us that there is no benefit on overall survival. Only one trial among them, that was a Turkish study, which actually showed a benefit, had predominantly bone-only metastasis and oligometastatic profile of the metastatic patients. This benefit in bone-only metastasis or oligometastatic disease has been proven in many other retrospective prospective series as well. So indeed, role of surgery in polymetastatic breast cancer is declining. There is no overall survival benefit, which is recognized now. Systemic therapy is offered first and a case-based selection is done after that for offering palliative surgery to patients who deserve it. And oligometastatic breast cancer is a special subset. It is treated as of now with a curative intent. However, it needs more prospective, well-documented databases, if not a randomized trial. Coming to omission of sentinel node biopsy, I think Dr. Megha Tandon presented this in the morning in node-negative patients. And this is in elderly women who are probably screen detected T1 tumors who have good ECOG performance status. they propensity matched 1:3, around 1,500 patients with 12,000 patients who did not undergo a sentinel lymph node biopsy and those who did undergo a sentinel lymph node biopsy. And sentinel lymph node biopsy node was positive in patients who were larger tumors like T1C tumors, central in location and with lymphovascular emboli. And it was also associated with more likelihood to receive chemotherapy and radiation thereafter. However, omitting SLNB did lead to a lower overall survival, and that was probably related to having an impact on adjuvant therapy treatment decision making. In another such analysis, which was discussed in last year's SABCS, they also showed a lower breast cancer specific survival in women who did not undergo sentinel lymph node biopsy at all. However, what they showed is if the patient was likely to receive any combination of chemotherapy, endocrine therapy, or radiation therapy, then this difference was offset, suggesting that if the patient is likely to take hormone therapy in the adjuvant setting, you may omit sentinel lymph node biopsy. So of course, it requires good clinical radiological evaluation of the axilla with FNSE if required, and you need to consider adjuvant therapy planning as well, like endocrine therapy in this group of patients. Counseling patients, individualization of treatment and shared decision-making would be utmost important here. Coming to the last two abstracts, which is omitting surgery post-neoadjuvant chemotherapy in responders, which developed quite some discussion, which induced quite some discussion in the last session. And there is indeed an increasing use of neoadjuvant therapy, not just in locally advanced, but also in operable breast cancer to achieve a PCR. However, earlier we knew that there is PCR or not only by operating on the patients. So there were studies which looked at image-guided biopsies to predict, or imaging to predict PCR. However, they failed to meet a good FNR and a negative predictive value, which was not so low. Hence, only one study from the MD Anderson showed a good FNR when multiple number of VABs were used, core biopsies were used. So in this Japanese study, which Dr. Vaishali presented, VAB was used, the 6 core biopsies were taken with a large gauge needle under ultrasound guidance and with VAB assistance from the tumor bed. After evaluating that there is complete clinical response on not just clinical examination, but also on MRI and ultrasound. However, it still failed to meet the false negative rate, which was as high as 33%. And the authors rightly concluded that they do not favor omission of surgery in this group. The topic that Neha presented, which was intelligent VAB, using this artificial intelligence to identify PCR. What was interesting here, they just didn't do a VAB biopsy from the primary bed, but they also considered patient demographics, imaging characteristics, and tumor biology, as well as the axillary nodal status as seen on imaging into context, and developed an AI algorithm to test PCR versus not, or to predict PCR. And they had a test training set and a validation set, where they did manage to meet an FNR of less than 5% with good correlation with the training set as well as the external validation set. So maybe intelligent VAB testing, it can be evaluated in future trials. So to just conclude, Hodgkin's disease and breast cancer, yes, we probably need to discuss doing more with our patients. Surgery in stage 4 breast cancer, we can omit it completely in polymetastatic disease unless there's a specific indication to do so. Omission of sentinel node biopsy, node negative elderly patients, not yet, but maybe if the INSEMA and the sound studies with their long-term survival outcome give us a positive result there, then maybe this group can have omission of sentinel lymph node biopsy, but not yet. And can we omit surgery post neoadjuvant chemotherapy even in responders? I would think the answer is not yet. Thank you very much for giving me the opportunity to discuss these 5 abstracts with you.
Thank you, Dr. Joshi. That was indeed a fantastic presentation. We loved it, to summing up all the presentations. We go to the questions at the end. And may I now request Dr. Nita. Dr. Nita Nair, Professor and Consultant Surgeon, Department of Surgical Oncology Breast Services, Tata Memorial Hospital, Mumbai. Nita, you can start now.
Sorry, just a second. I'm going to reshare it. Are my slides visible to you, sir?
Yeah, fantastic.
Great.
Yeah,
thank you very much. And again, good afternoon to everyone. I think we're running a little late, so we're just going to run through this. The opportunity given to me here is to talk about the abstract on oligoprogressive disease that was presented by Amy in one of the educational sessions. We heard Vedant sum up very well on the SEER database and the current status of surgery in metastatic breast cancer. And this topic or presentation was more about a radiation's perspective for oligoprogressive or oligometastatic breast cancer. The concept of oligoprogressive or oligometastatic was first coined by Hellman and Weisselbaum way back in 1995. It talked about how there was a certain group of disease, which was metastatic breast cancer, which did not behave as badly as widely or polymetastatic breast cancer. And we need to be able to identify and recognize that group. There are three concepts in the spectrum of oligometastatic that they talked about. One is somewhere where it's induced because you've given systemic therapy, there's only a single site that's now residual, versus whether it's a synchronous MET that develops after treatment of a non-metastatic primary breast cancer, or in metastatic breast cancer, a second site presents after all the systemic therapy that has been given. Please understand, with the changing landscape of systemic therapy, we're going to start seeing a lot of this much more than usual. One of the concerns that we are now facing is that we've always talked about oligometastatic, polymetastatic, or oligoprogressive disease, more about just pure biology of disease, DFI. We need to start recognizing that there is something very distinct in the genes expressed in these specific cancers, and the cascade is a little different in the oligometastatic lesions compared to the polymetastatic. When you talk about treating an oligometastatic lesion, you've heard all our speakers talk about treatment of the primary. What you need to keep in mind is also treatment of that distant disease so as to allow the patient to go into a phase of remission. Now, this treatment of the distant site can happen by various methods of radiation, be it stereotactic body radiation, EBRT, radiofrequency ablation, and of course, surgery. So when Amy talked about the concepts in that educational session, she focused primarily on the ablative techniques of radiation because I would say stereotactic ablative radiotherapy, or SABR, is now becoming a very popular concept in the treatment of these metastatic sites. So we know of the three types of ablative radiations, SBRT, SABR, and IGRT, that are commonly used. And there are older studies, most of which have been in other cancers. The Saber Comet was mixed bag of cancers, where about 18% were breast cancer. They looked at standard treatment versus stereotactic ablative radiotherapy. And though the study was designed to take in patients of less than 5 lesions, over 70% of the patients included in that study have less than 2 lesions. And despite that, it showed that there was a benefit of SABR, and there was a trend towards using it more and more into our population. Please understand, these are all phase 2 randomized trials. These are mixed bag of cancers and primarily focus on biology of that oligometastatic disease. When you look at the Saber Comet study, again, to reiterate the same point, there is a definite improvement in outcome when you treat the metastatic site versus standard of care or observation. So I think we are definitely moving towards treating that metastatic site in patients that we coin as oligometastatic or oligoprogressive, so as to create that phase of remission. And I repeat myself when I say that, because again, you must understand, if you leave that distant site unattended, you are going to potentially see more progression in the future. Another study which she focused on talked about looking at the type of biology. And of course, as we expect, worse outcome was associated with those who had poor DFI, worse biology like triple negative, and we need to start identifying our patients in our MDT. There are multiple studies ongoing evaluating exactly the same. CURB was presented as an interim analysis in the last ASTRO meeting. It just said that you can, there is an emerging group which is supposedly doing better with the use of SABR. Saber Comet, I think, is stretching it a little. We're looking at patients with up to 10 sites of distant disease that are going to be treated with stereotactic ablative radiotherapy, but we are taking it forward in a big way. So with all the de-escalation of therapy that you've heard since the morning, we're not now talking about escalating therapy for that distant site. What you must realize, and this is the summary that she stated, which was emerging data now tells you that there is a molecular understanding for this metastatic evolution. It's not as simple as type of biology and response to treatment. So we need to start taking more cognizance of that. Radiation therapy is evolving in a very effective manner with stereotactic ablative techniques and tumoricidal doses. But I will reiterate over and over again that these need to be MDT decisions and taken together in the best interest of the patient. At the same time, in 2021, we saw a SEER data, a national cancer database registry submitted, which talked about treatment of that secondary in de novo stage 4 breast cancer. Now, these aren't all oligometastatic, they're polymetastatic and oligo. They talked about just a group of patients that were treated. This is 2010 to 2017, little over 22,000 patients, where radiation was, as expected, more commonly used. But what was interesting to note is that surgery was possibly the better answer in patients with visceral disease, be it liver, lung, brain, and as expected in the multivariate patients with less than one site did better, with one or less sites did better than those with polymetastatic disease. But I will tell you that this is slightly older data, so the use of stereotactic ablative therapy may have been less. This is primarily evolving RFA and EBRT rather than the more advanced radiotherapy techniques. So I think we've really come a long way when we're discussing metastatic breast cancer and treatment of the same. We have to start recognizing that metastatic breast cancer doesn't always have a poor outcome. We are seeing more long-term survival because of our expanding systemic therapy, and we need to recognize the concepts of oligometastatic and oligorecurrence as two separate identities. We have to look at biology, disease-free interval, responses to treatment, and of course, the patient's ability to take treatment. Controlling the metastatic site in an oligometastatic or oligoprogressive disease, I think, is the way forward, in addition to locoregional therapy. And the advances in radiation with the ablative techniques of stereotactic ablative radiotherapy are now an emerging role in the current management. Thank you.
Thank you, Neeta. We will take the questions and discussions at the end. I now invite Dr. Geeta. Now, Geeta, and she doesn't need introduction, but it's customary to introduce her. She is the Senior Director, Breast Surgical Oncology, Max Healthcare, New Delhi. Geeta, would you start sharing your slide and start? Yeah, thank you very much.
Thank you. Thank you, Dipendra, for the kind introduction. So I'll be talking of, we keep talking about metastatic disease, so we have to find a way and recognize those subsets which will actually benefit from surgery and leave the others to systemic treatment. So this is the study which was presented by Anthony Lucci at the San Antonio in 2021. So we do have these prospective randomized trials, which have already been alluded to by Vedant, so I will not go into this. I'll just try to go straight to those subsets which can possibly benefit. And I would look at this study, which is the MF0701, which is the Turkish study, and tease out the special subsets benefiting from surgery in stage 4 breast cancer. So we do know here the essential endpoint was overall survival and locoregional recurrence and relapse. So this was the randomization that was done, which has already been shown by Vedant. So what we have to understand here is which is that subset which will allow us to get better results with surgery. More HR positive patients actually were there in the locoregional therapy arm, and very low rates of PNBC, and look at the bone only metastasis, 51%. So we are getting a picture now which is trying to show us which are those patients. So at 5 years, they could see that the locoregional treatment arm was doing better, and that's not surprising considering that more than half the patients were ER/PR positive. And then this is what the subgroup analysis finally concluded. ER/PR positive had a longer survival in HER2 negative, better survival with younger patients, and bone-only metastasis. So you have to look at it in a nuanced manner and offer surgery only to the favorable subsets. So this is the BOMET study, which will further refine who gets surgery in the metastatic situation. So this is only bone metastasis and compared to locoregional with systemic treatment. Again, progression-free and overall survival were the endpoints. So this was the study design, 505 patients randomized equally to systemic and local regional therapy arm. So surgery group, again, younger, surgery group was younger than the systemic group, more T3 tumors were more, and you're looking at all these bone metastases, whether solitary or oligo or multiple metastasis. And what they saw was that the median survival, life follow-up was similar in both groups. But what we want to bring your attention to is the 5-year overall survival. And you can see how the curves are separating, whether local regional treatment happened before systemic treatment or after systemic treatment. So surgical intervention did contribute to improve survival in hormone receptor positive and HER2 receptor negative, and also the HER2 positive group. And triple negative has definitely not shown a survival benefit. So that brings more clarity to those patients on whom you can offer surgery. And by the same thing, by overall survival and tumor subtype. So in de novo stage 4 breast cancer, we do know overall survival by tumor subtype is clearly established that the HR positive ones do definitely better as compared to triple negative breast cancers. So local regional therapy is independently associated with survival in this study, and even with multiple bone mets, you are getting a survival benefit. So this is purely for bone only, and of course ER/PR positive and HER2 positive. So then the other subset that one wants to look at is inflammatory breast cancer, which has been always treated as to be treated systemically is for all, as long as we know, but we do know in the past many years after systemic treatment, we do offer mastectomy to these patients. And now they are talking about doing it in a metastatic setting also. So this is the role of metastatectomy. As you can see, 58 months in the MRM group as compared to 19 months in the non-MRM group. So a pretty good difference that you can see in those who are treated with surgery for the primary, even in the metastatic situation in IBC. So this is a multivariate analysis, again showing that the surgery, of course, is an independent variable and shows significance in inflammatory breast cancer. And this is another study which has shown better survival with surgery in the primary in stage 4 inflammatory breast carcinoma. So these are both surgery versus no surgery in matched and unmatched cohorts. And again, in the non-matched cohort, you can see the surgery of the primary is allowing for a better survival. And that brings me to the last bit, which is contralateral axillary metastasis, which should it be clubbed together with stage 4, possibly not, and there is an attempt to ensure that it comes into a stage 3 in the AJCC TNM cancer staging. Stretch it a little bit for the inflammatory breast cancer also. There also we seem to be seeing better results with surgery and radiation to the inflammatory breast cancer. This is all retrospective data, unlikely that we will see a lot of prospective data in this space. So MRM of primary tumor appears to offer a better overall survival. Contralateral axillary metastasis, should we really be looking at it as stage 4? Possibly we need to be aggressive in our approach in treating contralateral axillary metastasis and offer surgery and radiation to IBC patients contralateral axillary metastasis alone. And of course, for the purpose of improving quality of life, surgery for patients who are symptomatic or who have an LABC, that also needs close consideration. Thank you very much.
Thank you, Geeta. I suppose you have put our morale bit higher up. I was hoping that we should not be discussing breast cancer. Thank you very much for keeping the hope burning. Now I go to the last speaker, Dr. Arun Goel. Dr. Goel is the Director of Surgical Oncology and Breast Oncology in GI and Hepatobiliary Oncology at Max Super Specialty Hospital, Vaishali. And may I request Dr. Goel to start his presentation, please.
Thank you, Dr. Sarkar.
Very good afternoon. In this session, there has been a lot of overlap and repetition, so I try to avoid repetition wherever possible. The abstract that I am discussing basically again is part of a educational session, and the speaker was Dr. Seema Khan, who is definitely a pioneer in the field of bringing surgery for the primary tumor in de novo metastatic breast cancer to the forefront. De novo metastatic breast cancer is constituting about 6% of all breast cancer diagnosed in USA. The proportion is definitely higher in India. The figure is in double digits, and it is similar in other developing countries. About what should be the treatment approach in these patients, whether we follow Halstead, whether we follow Fisher, or whether we follow Hellman. So over a period of time, definitely the spectrum theory is having sway now, and it is based on the spectrum theory that we are trying to find a subgroup of patients in having de novo metastasis who could probably have a better potential to be treated successfully. One of the other reasons is the advances which are taking place in systemic therapy based on a better biology. We are able to achieve higher and higher pathological complete responses. So there is a possibility that we may be able to eliminate metastatic disease, and when we are able to eliminate metastatic disease, then local treatment might become necessary. But the question is there evidence to support this change, and has our approach changed? So Dr. Vedant also presented about the time trends in the usage of surgery for primary. So as I said, there are multiple subgroup of patients. This understanding has come in last 1 or 2 decades, and we know that they all behave differently. So currently, in HER2 disease, which was previously considered as a bad disease, now with HER2 targeted therapy, we have one of the best possible outcomes. So the extent of metastasis also, we can have solitary bone metastasis, bone only metastasis more than one, oligometastasis in other organs, and other category of patients. And I think each of them have a different potential to be treated. So the question is it possible to cure any of these subgroups? Does surgery for primary tumor improve overall survival, and is there a gain in quality of life? What are the possible explanations? One, systemic therapy could take care of metastatic disease, but not the bulk which is there in the primary tumor. So a combination of systemic and local therapy may be necessary. Then it has been proposed that primary tumor is a source of further metastasis, and eliminating it could be beneficial. Then components of the primary tumor or stroma could be promoting development of metastatic disease. And in addition, untreated primary tumor leads to fungation, bleeding, pain, and it is also a cause of psychological distress. So the journey began in 2002 with the publication by Dr. Seema Khan from the NCDB database, which Vedant also referred to this. So the median survival was 19.3 months without surgery, 26.9 months with partial mastectomy, and 31.9 months with total mastectomy. And multivariate analysis also showed that surgery was associated with better outcome, and a hazard ratio for survival was around 0.6 with surgery. So based on this, it was said that retrospective data is not a basis for changing your practices. So prospective studies should be started. Multiple prospective studies have been carried out, but recently this large NCDB database has also been published. And this database shows that surgery definitely is associated with a better outcome, and trimodality therapy was associated with the outcome which was better than with bimodality therapy. So patients who had both surgery and radiation had a better outcome. So in this setting, 6 randomized trials have been described. But there are three major trials: the Tata trial, the Turkish trial, and the one in which Dr. Seema Khan is associated, the ECOG-ACRIN. So we have had a lot of discussion about the Turkish trial. The Tata trial has also been discussed in detail. So I'll focus on this ECOG-ACRIN trial. This enrollment happened from 2011 to 15. Breast cancer with metastatic disease started with registration. Systemic therapy was initially allowed or required for a period of 16 to 32 weeks, minimum of 16, maximum of 32, and patients who had no progression or disease. So they could have response or they could have static disease. They were randomized to surgery or no surgery. Radiotherapy was used as per NCCN guidelines. So the trial basically registered 389 women and 1 man, and finally 256 patients had non-progressive disease who were randomized, of which 131 in the group of early local therapy. So I would like to highlight that this trial had planned a randomization of 660 patients. So that means a registration had to be on a much higher number. And the initial approach was to look for a survival gain from 30% to 45% at 3 years. So because of low accrual rate, finally only 256 patients have been randomized, which is around 40% of the target. And the estimate is that the trial has a 85% power to detect about a 20% difference in survival at 3 years. So let us say a smaller difference of 5 or 10% in survival will not, theoretically, it doesn't have the statistical power. Again, the spectrum of patients, only 41 patients had oligometastatic disease, so which is less than 20% of the total patient population. Of the patients who underwent surgery, so 125 patients were randomized to surgery, only 107 underwent surgery. Surgical margins were tumor-free in only 98 patients, and surgery was completed within 3 months in 101 patients only. So there are certain gaps when it comes to the surgical group also. The median follow-up is 53 months. 3-year OS is 67.9% for systemic therapy and 68% for surgery. So the initial, when the trial was projected, they estimated the 3-year survival was 30%. So these figures are actually much higher. The median OS is 53.1 months and 54.9 months. Subgroup analysis also did not show any difference either for oligometastatic disease or for bone-only disease. So locoregional progression definitely was significantly more common in the systemic therapy arm, but there was no difference in the health-related quality of life in the 2 months. So the authors concluded that trial results do not show any improvement in overall with incorporation of surgery. There is no benefit in any of the subgroups. Imbalance between the two arms, and which could be responsible for the survival differences which are observed in the Turkish trial. So based on this presentation and my analysis of the paper, I would say that while the available data does support for routine use of surgery in de novo metastatic disease, but the randomized trials also do not put a final may derive benefit. There are certain eliminated patients with a favorable disease and they were not randomized. So patients with bone-only disease. So what we probably need is that carefully selected subgroup of patients would be sort of considered as of now in tumor board settings and maybe for a future well-planned trials. Then also the issue which has been discussed is whether targeting both the primary site and the metastatic site might be worthwhile. So as of today, I would say that none of the surgeons is willing to totally give up on locoregional therapy in a very favorable subgroup of either bone-only disease or solitary metastasis, particularly patients who show a very good response to systemic therapy. But the question is open. Only thing is that the results of randomized trials should not be used to deny a very favorable subgroup the possibility of some benefit from using local therapy. Thank you.
Thank you. Thank you very much. So we come to the end of the presentations, and I request everyone to be on board and let's start the discussion. We are running behind the schedule and therefore we need to move a bit faster. Now, taking into consideration everything, I mean, it's like a one-day match. Once I feel surgery is required, the next moment I feel it is not so important. Now, I start with Vedant to begin with. Now, Vedant, now you have looked into this trial, which ranges from the last 2 decades almost. And looking at that, I feel, I want to take your take. Do you think actually the definition of metastasis, depending on the tool that was used to diagnose metastasis, may be an important factor in conclusion of the different trials?
See, most of the trials that we are discussing have been from an era where PET-CT is quite extensively used. Yes, we can have a change of definition of oligometastatic disease, but defining and diagnosing metastasis, probably not much of a difference. Maybe difference in the sensitivity of the study, improvement in the techniques of the PET-CT and other things, yes. But otherwise, these durations, last 15, 20 years, Western world has been using PET-CT quite a lot. So I don't think that would really make a difference.
Now, Neeta had been with this TMH trial. Now, the TMH trial, what was the tool mostly being used to diagnose metastatic breast cancer?
So I think it was what was the standard of care for us always, which was a CT scan, bone scan among the private patients, a CT scan, bone scan, or even just an ultrasound of the abdomen for the general category patients. What I can tell you is that we've actually now got 100-month analysis follow-up of our patient profile. Median survival in the 2 groups is 19 months and 20 months with absolutely no difference in overall survival, even at 100 months of follow-up. So in a polymetastatic disseminated group, I think a lot of the data is showing a very single direction of no benefit. The concern that exactly what you're raising is that with the increasing use of PET scans, we're picking up a lot of indolent, small volume oligometastatic disease. And I think that's where we're changing our thought process a little.
Yeah. The next question, I would go to Shalaka. Now, what is your take on omitting sentinel lymph node biopsy based on the study that you showed? Should that be omitted? And I mean, you are trying to de-escalating even at the lowest threshold. What's your take? Should it be off in elderly? I mean, their studies doesn't show that, but what's your philosophical take on that?
Technically, the subset of patients who's most suitable for omitting even a sentinel lymph node biopsy of the axilla is, I'm not even sure if that's well represented in the trials, because that would be somebody who has high comorbidities, who's not fit for surgery, who's not even fit for a small duration of general anesthesia, and you just want to get away with a quick lumpectomy under local anesthesia maybe in them. And that is not the kind of subset that we really see in our country. And these could be even screen detected a lot. And the National Cancer Database analysis that they did over really a long period clearly showed that patients who did not have even a sentinel lymph node biopsy had a worse overall survival. And that was consistent across 2 kind of retrospective assessments. What needs the INSEMA study that was also shows a worse outcome in those who do not undergo a sentinel lymph node biopsy. Seeing that in a randomized setting may be what we need to do and wait longer for the results of those trials. But the question that in a moribund patient, whether if she's going to take, she's strong ERPR positive and she's going to take future endocrine treatment, well, we may be able to avoid sentinel lymph node biopsy in that subset, but that really won't get represented in the trials. And that will have to be then personalized decision making for that patient.
Thank you. Thank you. Now, Nita, looking at this, what are the important factors? I mean, we have been at a personalized medicine level in early and locally advanced breast cancer. Are we going towards a sort of personalized medicine in metastatic breast cancer as well? I mean, actually, your studies, apart from the number and the biological character of the cancer, raises the issue of studying at the molecular level and identifying the subset of patients. I would like you to elaborate more on that.
Absolutely. I think that's where we're moving forward, that now we need to not only recognize the difference in the volume or the burden of disease, we need to recognize disease-free intervals, we need to recognize what treatments these patients are going to be able to take. She presented talks about the genomic level with the difference in what is oligometastatic or polymetastatic. And I think chronology versus biology has always been a debate in early breast cancers and now even metastatic breast cancers, to understand that some patients, even though they have large tumors, don't have distant disease, while some patients with small tumors, irrespective of biology, have multiple sites of distant disease. So it's a little more than just pure biology. There is genomics that is interplaying with this, and we need to start recognizing that and moving in that direction.
Thank you. I go to my friend now who has been protecting me as a surgeon, and I don't see her in my screen. Now, Geeta, if I ask you, it's a far more difficult question. I mean, if I ask you to put weightage on three factors: at the character of the systemic metastasis, the extent of anatomical disease, and the extent of biological character of the primary tumor, how would you actually put weightage on these three? Which one do you think is most important, the extent and the biological character, or the character of the metastasis?
I think, we have to look at these two things separately. You cannot really compare it, because I think, we have to figure out biology and extent. That is a given, because that will determine response. And suppose you're starting off with systemic treatment and you're seeing an excellent response, one is almost forced to think, what more can we do to make this patient better? And that is where surgery kicks in. Looking at, it is possible. I mean, that is a thought that we need to pursue with more gusto, and that is to see if metastasis is different from the primary. And this theory has been going around, but I'm not aware of too many studies to show how the primary behaves, metastasis behaves. Are there different clones? By leaving the primary behind, are we actually giving rise to more resistant clones which can metastasize further and lead to a detriment? But of course, the subset with where I would put my money on surgery.
Okay, so I will come to Dr. Goel. Now, based on what we have heard, if I ask you to summarize for all the delegates, I mean, people are getting confused. What should be the approach for a postgraduate, a trainee, or a registrar level? How to go ahead? I mean, what are the factors to take into consideration? Should our approach be generic, or our approach be completely individualized? Your take, sir.
Yeah. Currently, no generic approach is justified when it comes to managing breast cancer. Nuanced approach is important, and tumor board forms the starting point. So we have the conventional biology. It is now being called conventional. So we have a hormone receptor positive, HER2 positive, or triple negative, and then we are having subtypes in triple negative. So that would be one. Then definitely, if there are metastases, then the number of metastases, the organ involved. So as I mentioned, solitary bone metastasis or a solitary metastasis, say in lung or liver, probably has a different behavior. And as Dr. Geeta also mentioned, I believe that when it comes to metastatic disease, the biological understanding of metastasis is still at a very early phase. We need to understand the drivers of metastatic disease, what sustains the metastatic clones, and probably we would need different sort of targeted therapies which would give us an advantage in eliminating metastatic disease. But for a trainee today, definitely you have to understand understand disease biology, the patient's age, performance status, comorbidities, and generally I say that when you have a patient with de novo metastasis, in most cases start with systemic therapy, look at the response, and only patients who show a good response, no progression of disease should be considered for any loco-regional therapy. So that would be what I would like to say.
Thank you, sir. So before we conclude, I will give each speaker 1 minute time to summarize and how they look at the treatment of metastatic breast cancer is going to go in next decade. The time starts with Vedant. Vedant, just a summary in 1 minute.
Okay. Although what I presented is a decrease in the use of surgery, but that decrease was mainly in a group which we would actually take up for surgery in today's time, which is hormone receptor positive, HER2 negative, or even HER2 positive with good anti-HER2 therapy and responding very well. What I see in future is, and as everybody has said, it should be oligometastatic disease, which in itself should also be amenable to treatment, so that we are covering not only the primary, but the oligometastatic disease as well, which is not yet been completely taken care of by systemic therapy. And in going ahead in future with immunotherapy coming in, we might be able to include even TNBC in the ambit of giving loco-regional therapy. Who knows? And so that may make you even more happier, Dr. Sarkar.
Thank you. Thank you very much. I go to Shalaka. Now, your 1 minute time to summarize things and how you're looking at the future.
Right. I'm now used to doing 1 minute per abstract. So I would say that the randomized data we have is very clear for polymetastatic disease, multiple systemic metastasis. And we have ecogacrin as the last nail in the coffin to say that there was no benefit in overall survival. However, we did see a benefit in loco-regional progression-free survival. Hence, a patient who is symptomatic, infection, bleeding, intractable bleeding, infection, pain, maybe these would be individual decision making for each patient. And in oligometastatic, the data is all over the place and there is really nothing prospective. There are good prospective series, but there is nothing randomized in this setting. If that's what we are going to consider as holy grail, then but then I don't know how to do a randomized trial when we are supposed to look into molecular genomics. So I'm confused in oligometastatic disease, how to generate more data. Maybe we rely on all the prospective data and we continue treating them with a curative intent. And like Neeta said, treat also the metastatic sites. First, let us define how many metastatic sites we are going to take, 3, 5, 10. So how much are we going to stretch the number of metastatic sites and consider them as oligometastatic? So that's still an open debate, I think.
Thank you. Now, before I go to Neeta, I was wondering whether someday we are going to sit and tell that there are a load of circulating cancer cell and you should be omitting surgery. I am unsure about that. So Neeta, 1 minute for you.
So I think I'm just going to say a couple of buzzwords. One is the surgeons aren't going anywhere. So I think with all the de-escalation, there's always going to be space where we have a role to play because genomics is moving in our favor. Also, it has to be personalized care. It has to be MDT-based care. It has to be recognizing that patient's tumor biology, genomics, and what treatment she can take. I like the way Vedant said immunotherapy coming in, TNBCs. I am still to see a few patients who can afford that much immunotherapy, but hopefully one day we will be there.
Thank you. Geeta, before I go to you, now the government of India and the Ayushman Bharat is increasing more and more of, I was there in the meeting and I was astonished that the gamma, they are increasing now on modern medicine. Now, Geeta, your time of 1 minute. Geeta? Anyway, I will go to Dr. Goel. You summed it up last time. Your vision or perception of next decade.
You know, when Vedant says...
Okay, Geeta is there. Geeta, I think your net connection is somehow failing.
Shall I then?
Yeah, sir, you can start.
Yeah, overall, I am very positive or gung-ho about the future of oncology in general and breast cancer as a part of that. So I believe the understanding of genomics and other omics, which are all under development, and definitely finding more and more effective targeted therapies. The finances, the economics of using them is totally apart, but the ability to treat them effectively. So a multimodality approach and should be give us the ability to successfully treat more and more. It is not going to be a single major step. It is going to be chiseling away progressively. So maybe from one metastasis to 3 to 5, but ultimately we will get the ability to cure most of the patients. That is my.
Thank you. Geeta, now is the genomics of your internet connection doing better? Then
Are you able to see me? Are you able to hear me?
I am just not being able to see you, my friend.
Doesn't matter. Are you able to hear me?
Yeah,
yes.
Okay, so a lot has been said, but I think eventually it boils down to individualized treatment, and if it comes to the point when triple negatives are going to be treated with immunotherapy, be assured we will be eliminated at that point. If the disease were to disappear, and I'm sure the medical oncologist will make a case for not doing any surgery at all by that point.
Thank you very much. So before we end, if I am given 30 seconds time, I feel we should be investing now. We had a sort of mind frame in last decade, those who were trained and grew up together. We had a mind frame of hopelessness in metastatic breast cancer. At least 1.5 decades back, we were only talking palliative care. Things are improving, and it's time that we invest research on molecular genomics of metastatic breast cancer. And I feel the discussion today was good enough to indicate that there are 3 major facets. One is the molecular biology of the cancer itself, on which there are robust studies that luminal cancers do wonderfully even in the metastatic breast cancer setting when you treat the primary. Even today, I was astonished to find that inflammatory breast cancer was that subset is also doing an overall survival advantage. The extent of metastasis and the location has been hugely talked about in last 2 decades, and that was possibly the only area we were debating. The Turkish group and the Mumbai Tata Memorial Mumbai, that was the major debate. When should we do metastatic based on the anatomical number only? And I'm sure the next decade is going to see a burst of genomic studies on the metastasis, and we are possibly heading from an hopelessness to a complete hope based on the profiling of the metastasis and the primary tumor, and then a focused individualized treatment in metastatic breast cancer. Thank you everyone for being part of it, and once again the organizers for giving me the opportunity to moderate the session. Thank you very much. A warm good afternoon to everyone, and I would request the organizers to take over, please. Pooja?